Modern medication did not work for me. Modern medication did not work for me. Modern medication did not work for me. Modern medication.
Good morning. This is Tom Burns. We're going to go ahead and get started.
I just want to let you know that I'm going to be in and out of court, so I'm going to have to come off and on.
I understand. We will, when you come in, we've taken the beep off, so we won't know when you come in or leave, Senator. But just, let us know when you want to jump in by making a loud noise, and we'll know you're there.
That sounds great. Did you get the little piece that I sent to you late last night?
I did. I appreciate that, and we will definitely discuss that.
Thank you.
Okay. So let's go ahead and get started. Let's do introductions so that we people all know who's here, and people on the phone can introduce themselves as well. Anthony, you want to start at your end?
Yeah, Anthony Johnson, Oregon Cannabis Industry Association and New Approach Oregon.
Jack Crabtree, Yavapai County Sheriff and representing the Oregon State Sheriff's Association.
Rob Levat, Lincoln County District Attorney, representing the Oregon District Attorneys Association.
Jeff Sugarman.
Tom Burns with the Oregon Health Authority.
Todd Delato, Chair of the Advisory Committee on Medical Marijuana and President of CAN Research, Horticultural Science and Industry Consulting.
Paul Schmidt.
Noel Bullock, Chair of City Compassion, representing dispensary proprietors.
Shannon O'Fallon, Department of Justice.
Okay, and who's on the phone? Senator, we heard you. Who else is on the phone? Okay, for those of you who are in a listen-only mode, don't panic that we didn't hear you. There's two sides of this. The RAC members can communicate with us. Everybody else is in a listen-only mode. So I appreciate it. Okay, we're coming down to the end, quite frankly. For a number of reasons. One is I think that the advice that you have given us and the work that Shannon has done has created a document that I think is pretty close to finished. We can make some changes. So that's timing number one. Issue number two is that I have to, by next Friday, turn this over to the people who do whatever the people do in order to make this an official document and post it out there so that anybody who wants to open a facility has rules that they can function under when it comes to applying for March. So our absolute drop dead date is next Friday. We're taking it internal. I've got to clear it through the director's office and through some other internal people who want to see this before it goes out. So we're probably going to finish writing this on Friday and spend a week getting it cleared so that then it can do whatever it does to get posted, and you guys in the audience can start applying for your licenses. Since the last meeting, we have made changes. It's the usual track changes that are in the document. You can see those. The major ones were that we redid a lot of the testing stuff. We put a list of pesticides in that will need to be tested for. We redefined how the whole testing process was going to work. I know there was a great deal of concern about certain percentages of the product and how much product was going to be sent off to be testing, and the concern for that went away by simply it's between the laboratory and the facility about how much product needs to be used to test. We still reference THC and CBNs. I am now convinced that we need to make it THC and all cannabinoids. Cannabinoids, with another squabble in there. So that has been cleaned up. I think that we put some stuff in here about how to close a facility if the facility does ultimately get closed for whatever reason, what happens there. A little bit cleanup on some of the transfer stuff, and the rest of it really is just relatively minor. I will point out on an issue that everybody's very concerned about on consumption that we now understand the concern about employees who need to medicate and the fact that they do need to be able to medicate on site. So you will find in here that employees can medicate. It is still the health authority's position that nobody else should medicate on site. That doesn't mean that a next door facility, next door office, whatever it is owned by the dispensary can't open. We're not looking at that. We're only focusing on the dispensary. So other than that, at this point, I think it's time for the committee to just start commenting to us about, you know, why, what, where, when, how you came up with this language. Senator Przansky, if you're on, do you want to raise your issue right now?
Yes, I do. Basically, what I just wanted to do on the enforcement section, there's a sub 7 that's within enforcement provisions. And I needed some clarification as to what this was going to allow the authority to do in the sense of reporting to either local jurisdictions, what I'm assuming would be some type of compliance code or building code issue. I'm just not sure exactly how broad that would be. I also question whether the language on the first line says may constitute criminal conduct as compared to having a good faith belief that it actually does somehow violates criminal conduct. It seems to me to be a tighter standard and be more clear, and it would be one where I thought it might be something, so I thought I had to call somebody. And I think then the last part of that portion was local jurisdictional issues regarding other state statutes. I'm just not sure how an Oregon business that's operating in Oregon is somehow going to be violating their some other states' ordinances or statutes, excuse me, that would need to be reported by the authority.
I don't know. Shannon, do you want to respond or?
So on your last point, this is Shannon. Other state governmental entities means other state governmental entities within Oregon. So Oregon OSHA, the state fire marshal. It does not refer to another state. It's other state governmental entities. With regard to sort of the broader question, I mean, we can look at tightening up. I certainly would assume that the Oregon Health Authority would not be reporting things to other entities that have jurisdiction without a good faith belief that there's a violation. I think that goes without saying, but we could certainly put that in there. This is language that you see in other rules that govern other, regulated entities. That if you see something that might be a violation of another law, you have the discretion to report that. It doesn't mean that it's going to get reported.
So Shannon, an example might be if an inspector walks in and discovers that there are frayed electric cords running around the perimeter of the building because that's the way they build an electrical system, then they might want to raise that to somebody, call somebody. Is that what you're envisioning? Yeah,
and I assume this is a situation where the authority would first point that out and say, hey, that looks really dangerous. You should take care of that. I don't know of any agency that the first thing that they do is pick up the phone and call somebody from another sort of governmental entity and report them.
And Senator, as the one who's at least in the process of hiring staff and are going to be training the staff, there's no way that they're going to be experts on building codes or fire safety codes or any of those things. This is going to be something where clearly there's an issue that was not addressed and the facility wasn't interested in addressing, and it's sort of, I'm really nervous and I think someone who does understand this ought to come in and look at it.
Right, and I think
Tom, that sounds fine for me. I think what I would suggest is that 7 be kind of tightened down, that would be an option if they don't come into compliance or address the issues that are raised through the informal or the formal complaint process, because that sub 7 is a standalone within the enforcement. It seems like that would be a tool that should be used after the people don't come into compliance or take serious the concerns that are raised by someone for the authority.
Point taken.
I think the other, this is Shannon again, the other issue for the Oregon Health Authority is, the health authority doesn't want to be in a position where something bad happens at a facility and it comes out that we knew about it and, hadn't reported it to other entities, so, yeah.
Are there similar rules in place for other agencies that do inspections?
Yeah.
I have a kind of a related question. In the very first section, under applicability, we've also added the words "or local" under laws that facilities need to comply with. My question would be, if a city, for example, said that we won't issue a business license because this is in violation of federal law, does that mean that the facility or the PRF would not be able to operate because they would be somehow in violation of a local law?
I mean, it wouldn't be something that would keep a facility from being registered, but that would be an issue that the facility would have to deal with the local jurisdiction on.
And it's also designed to make it clear, there are fire marshal laws in the state, there are building code laws in the state, and when you do something like this, when you open a facility, you have to meet all those other things that are out there. And
But I'm concerned about the specific issue of cities and counties actively trying to ban dispensaries from being there. And if we're requiring the facilities to comply with local laws, and the local law says you can't be here, are we then actually saying you can't be there, you can't operate there?
well, again, we're going to issue them a license.
But then why are we requiring them to comply with a specific local law that would not allow them to operate?
I don't think this language does that.
I'm looking at this section right here, Ron.
Oh,
The very first section. I switched sections under
Page
Page
1,
right after.
Sub 2.
1000 sub 2.
This is Shannon again. I guess I see this as a disclaimer,
Yeah.
saying that just because you're registered doesn't mean that you don't have other legal obligations, and what those obligations are going to have to be worked out on the local level. I mean, the Oregon Health Authority cannot tell local jurisdictions that they have to allow these facilities to operate. I mean, I think that's it may be a legal fight that ends up happening between facilities and local governments.
And I totally get the piece about building codes and things like that, but what we're saying here then is we're actually requiring facilities to comply with local law.
We're saying that registration doesn't exempt you from compliance with other laws. We aren't saying that you're affirmatively required to comply with them. I mean, if a facility has a valid legal argument that an ordinance is, unconstitutional or, otherwise illegal,
Preempted or whatever.
right, preempted.
But this would not then in any way prevent the health authority from issuing a license because the city came to the health authority, for example, and said they're not in compliance with our law, or to yank their license for some reason.
I don't see how it could.
Right, the authority will not be evaluating applications and will not be looking at whether or not they're complying. It's just really a notice out there to say, hey, look, just because you're registered doesn't necessarily mean
That
I mean, there's employment law, there's all that kind of stuff that local and state laws have to be applicable.
And I understand that, and I'm not saying that facilities
Signage
shouldn't have to comply with those laws. I'm really going after, I just want to get on the record this specific issue and how the health authority is gonna deal with that should a situation arise where a city says you can't operate here. And
I don't see the city being involved in the decision process by the state to issue a license.
The way I read this is that if an inspector who probably isn't trained or has experience in a broad range of types of violations sees something that in their judgment may constitute a violation, that the OHA may report them to the appropriate enforcement agency. Is that what I'm getting?
You mean in the other enforcement section? Not what we were just talking about, but the...
Back to the enforcement section.
Right.
That's the way I read it.
Yeah,
Right.
yeah. So with that, I do have a problem with the word may, because that is a judgment call, and I don't expect all the inspectors to have enough experience with a wide enough variety of enforcement violations, whether it's building codes, or money laundering or something. So I just don't want to see a situation where an inspector uses their judgment thinking that it may be a violation and then goes and reports them to another enforcement agency, causing problems for the dispensary that they may or may not be violating. So maybe if we change that to something that, you know, that does constitute criminal conduct, you know, something more definitive.
Well, then you're requiring the inspectors to know the answer to whether there's criminal conduct.
Yeah, it doesn't.
Well, I think if they report somebody to another enforcement agency, I think they should have a good basis for that they are violating something.
So they walk in a room and they see the ceiling collapsing.
Mhm.
Do they need to be a building inspector to know that the ceiling is collapsing?
Some things are clearly obvious to people.
But
so,
it may
yeah.
simply be that the panel came loose of the hang-down ceiling,
Mhm.
and the building itself is functionally fine.
Mhm.
I mean, that's, I mean,
Yeah, that's
I understand your concern, but again, I think that either you ask them to be experts, and when they see it, they report it, or you say, we're hiring you to use your best judgment, and you make the best judgment, and we're not harassing you, we're not going to ask anybody to go and harass the facility, we're simply saying, there's something that doesn't feel right in this situation. Would you, the fire marshal, would you, the building inspector, would you, the whatever, the employment agency, go in and look at this and see whether I'm seeing something, maybe I'm crazy, but.
Yeah, it seems to me the options are either may or shall report, and I think may, the judgment call is probably the best tactic to take care of.
Oh, it was the other may I was referring to. Discovers violations that may constitute criminal conduct or conduct that is in violation. So I think that may, you know, should be something more definitive.
I disagree. I think if we make it more definitive, we're asking these inspectors to know more than we really need them or want them to know. I wouldn't want these inspectors making preliminary decisions about whether or not something constitutes violation of building code, whether it constitutes violation of fire code, whether it constitutes a violation of criminal code. You know, I think that's expecting too much of them. And I think the second may really is, I like both mays, because I want them to say, hey, this might be a violation or not, I'm going to refer to the right agency, and then also have the ability to go to the facility owner and say, hey, I think this might be an issue, take care of it. If not, I may have to refer to somebody else who knows something about this. I think language makes perfect sense to me.
Yeah, I'd say at that point, there's no way to know if criminal conduct's been made, so, you know, I think maybe appropriate.
No, I got 2 of them, 3 of them up here, 4 of them up here. Jack, did you want to?
No, I just.
Okay, sorry.
And just to reiterate kind of Jeff's point, and I think Shannon's point on the applicability on section 1, so nothing in these rules say you don't have to comply, or you have to comply with other applicable state or local laws. That's just a disclaimer, similar to if it said this doesn't exempt you from federal law. Right?
That's the way I read it, just a disclaimer. OHA, kind of a CYA thing.
And if I could just add, not to relieve Todd here, but just from personal experience on inspections and that, with the may and may, it's very easy when you're doing an inspection at a medical dispensary and you look at a door that supposed to have a commercial lock, and not knowing the definition of a commercial lock, and it precludes intrusion for so many seconds and the use of torch and pry bars and so forth. But when you look at the outside door and you see it just has a simple home lock or a quick set lock, and those were the sort of things that a normal inspector would say, hey, this really doesn't look commercial grade to me. Do you have paperwork, or did you have someone install it, a locksmith or whoever, that could certify, yes, this is a commercial grade 1 or 2 lock or so forth. And those were kind of the things, like not referring it, to the health authority or to some other authority. It was kind of on your checklist. You went down these things and said, when I come back in 2 weeks or a week, could you please have that lock changed, or something verifiable that says, no, that is a commercial grade lock or whatever. And really, it stayed in-house more than anything. And the only things that ever really went outside of house were something that was so obvious of a health nature, or the building fire code, you know, those sort of things. When you saw 37 extension cords plugged into one socket, trying to do high pressure sodiums and metal halides and that sort of stuff. But I'm just saying, that's kind of the route it took, and that's why I think with everybody that may just leaves it up to common sense application.
Senator, were there any other issues? I know I don't want you to disappear on us. Apparently he has. Okay, Anthony, you want to bring anything up?
First on the discussion about testing for levels of THC, and you're thinking about going with all cannabinoids? Is that the?
That's what I keep hearing from people who have been feeding me emails, but
aren't there like new cannabinoids discovered all the time, and do labs even have all the the wherewithal to test for all the cannabinoids? And so it just seems to me that if we said you had to test for all cannabinoids, there would be no medical cannabis that would be allowed to be provided, because there's no way to test for all cannabinoids.
Yeah, there are only 3 easily available reference standards. You can get other reference standards, but they're very expensive, and not all chemical supply companies supply them. The one standard is a reference standard for, it's a triple standard for THC, CBD, and CBN. And that's the most readily available one, and you can buy it in a one-shot reference standard. And there are 80, over 80 cannabinoids, and some of them may only exist for a split second because they're in the middle of a biosynthetic pathway. So they may, so it would be totally irrelevant to measure those, because they're probably not going to be the same level as something is. And besides, there's only right now science has only looked at 2 cannabinoids with any great detail: THC, which we know a lot about, and CBD, which has been a hot subject of research for the past 10 or 15 years. And we're interested in THC because of its medicinal effects as well as its psychoactivity. And we're interested in CBD because we're finding it has a great deal more medicinal benefit than THC, and it's non-psychoactive. And the ratio between CBD and THC is very important because CBD modulates the psychoactive effects of THC, so that when someone looks at a lab result and sees the 2 numbers for THC and CBD, they're not so concerned with the total amounts of those, but more of the ratio of those, because they have a synergistic effect. So of course, we're not statutorily required to test for cannabinoids, but if the OHA seems committed to requiring testing for cannabinoids, I propose we test for THC and CBD. But then there's a bigger issue if we're going to test for those at all, and that's is that both THC and CBD have acid forms and several other isomers that have very different pharmacological activity. And of those isomers, the most significant are the acid forms. THC, the way labs test right now, or the labs in Oregon, the way they test right now, they report on a combined concentration of THC plus THC acid. Same with CBD and CBD acid. Only THC, delta-9 THC, is psychoactive and has the medicinal properties thoroughly studied. THC acid is only beginning to study their medicinal effects, and it's non-psychoactive. So when cannabis is in its dried, harvested, regular old form, a 20% something that would be reported as a 20% THC actually only has about 2 or 3% delta 9 THC, and the remainder in THC acid. And then there's also a calculation factor, because when you're calculating the mass of THC acid, you also have to consider the carboxyl groups,
Okay,
which
so
add
I adore it, but you've fallen in so far in the weeds. I got 3 initials,
Yeah.
CBN and CBD.
Yeah.
I get it, but
No, when you're getting your medicine tested right now, and they're doing a potency testing on it, what exactly are they coming back to you with?
We get a pretty holistic cannabinoid, terpene, and sequestered terpene analysis, way more data than we really have use for. What we put out for the prospective consumer is THC and CBD numbers. But like Anthony said, the darling of the day 2 years from now might be CBG or a different cannabinoid that we isn't really on our radar screen now. So, while Todd's exactly correct, we probably need a statement that's a little more, at least in rule, a little more timeless, that accepts the realities of today and what could be going on next year, 2 years, 3 years.
cannabinoid, that timeless statement.
Well, something like that.
But, okay, so if we said THC and cannabinoids, would we be then requiring a test for all cannabinoids? And do we need to somehow narrow that or to reflect
So
what
how
is
do we say
happening
not
out there?
all?
How do say
We
that?
would like some horsepower rating, but yeah.
It seems that today patients are concerned about THC and CBD, and if there are new cannabinoids discovered in the future that are pertinent, then new rules can be made to add the future cannabinoids. But today, THC and CBD.
Anthony, if I, real quick, back in my law enforcement days, and this is dating back into the mid-'80s and early '90s, a lot of sampling we sent down to the University of Mississippi for testing, and Todd was right on the money as far as NOLAs, and back then, what we had on our reports were the THC content, CBDs, CBCs, and CBNs. And that's kind of the standard that's always been, as they say, not that they can't change or new ones come back. But I was going to show you, there's a letter of one of the sample returns, and I think for at least a foundation to start from, those have been the ones probably most researched, most tested, and as you said, and at least it gives a foundation of where to start from, and if they need adjustment or whatever, at least you've limited.
So given that the charge is to produce a product that is consumer safe, if we had a label that listed those 4, THC, CBD, CBC, and CBN, is that enough information for a consumer to make a safe decision on what he or she is going to purchase and ingest? Yes. Use.
Adding CBC might, I don't think the majority of patients even know the effects of CBC. Very few know the effects of CBN. Adding CBC would add the need for a separate reference standard, which would be an additional cost to the lab, or eventually to the customer. I think CBD and and THC are really the important ones. But we also have to look at the acid forms too, because if the material is intended to be smoked or heated above 200 degrees Fahrenheit, then then most of the THC and CBD acid forms will be converted to THC and CBD when they're smoked. So some labs may report a combined result of the acid forms, and some may test just the non-acid forms.
But again, I get all that. Yeah. My question is, I'm a patient.
All right.
The goal is to protect me.
Mm-hmm.
What should I know? And I don't know the answer to the question.
Yeah.
You know, I mean, if the sense is that I walk in and I have an array of 20 different choices in front of me, and I want to purchase something, what should I know? Because all this isn't a test to say if you have it, you have to destroy it or anything. This is a labeling information only. So what should I, as a consumer, know when I look at this one versus this one versus this one?
THC and CBD, in my opinion.
Agreed. You could throw in CBN if you felt like it, but those are the big two. Those are the big three.
Except if it's intended to be smoked or vaporized.
Yes.
Right. But we need to get this right in rules because if it's not intended to be heated or smoked, or if it's already been heated or smoked and is in a finished product that's edible, if a lab report, then you're going to want the just the THC result. You don't want the acid forms, or you don't need the acid forms, because you want to know how psychoactive that's going to be. If the edibles are misreported, then people can significantly misdose. So that's why I'm boring you with all the technical jargon, because.
Amy, did you want to?
I realize I've not participated in the testing conversation really at all because I don't have a background in this, but I guess I'm curious, because I compare this to other states and I've been reading what Colorado is doing and other places. I mean, how far beyond, I mean, the statute just says, doesn't really address this issue at all that we're making the rules for. So, and I mean, I'm interested in potency testing. I think it's important, but I mean, how far beyond are we going in our rules? It looks like Colorado allows the option for it to say, if it's not tested for potency, and I know you're familiar with Colorado, for it to say, this product has not been tested for potency on it. So I'm not sure about making a rule that is so specific when the statute doesn't call for that. So, I mean, it seems, I mean, I'm far out of my depth when I listen to what Todd is talking about, but it seems to me that we should try and be consistent with what other states have done in addition to addressing what's actually in the statute.
I guess my answer, I was charged with patient safety.
Yeah.
So
I
that's,
mean, I think we should address potency, but I just want to make sure that it actually is fitting to what the statute says and consistent with other states addressing that issue.
And if that's true, if the whole issue is patient safety, then while it may be beneficial for them to know what cannabinoids are in there, the real issue is the THC.
And it's important that labs are reporting the same thing.
yes, yeah. No, I did that part, I get. Unfortunately, we haven't quite figured out how to reach the lab, but we're working on that.
Or that the results that the MMFs
Right.
receive, yeah.
Right.
Can I ask another question about the testing part? And again, I haven't participated actively, so if this has been addressed, then someone can just tell me that. In section 2, on page 14, a PRF must have written detailed policies. I think I should actually read detailed written policies, not written detailed policies. It's the modifier comes before the, but that's my grammar issue. But I think
I
that
failed English, so I don't know.
and I might be wrong about that too. So is somebody going to inspect those policies, the written detailed policies? Is that in there for some sort of enforcement purpose? So when they submit that, is the person reviewing this, is it going to go with the
It does not come with the application.
So what?
It's when I go in, I want to know the process by which the facility takes in product, finds product, decides, separates the product into the appropriate batches, sends the product out to the labs. All that stuff is written down, and it's the same time after time after time after time.
And so is that in some sort of like
A binder.
policy manual that the dispensary keeps
Yeah.
that's made open to
Yeah.
inspectors?
Yeah, and that we can just say, you know, are you following your policies around how the testing is done for your facility?
Okay.
That's all.
Okay. Perfect.
Okay? I mean,
Yeah. No, I just, yeah.
keep talking.
I don't want to
Go
keep
into
talking.
inspection as well as testing, since it's something to be inspected.
Yeah, I mean, I'm.
Maybe that's the point. Maybe it needs to be up in the testing, in the inspection section. I mean,
Yeah.
Be less ambiguous.
Okay.
I think that's probably, that makes sense, because how I think it reads, I think Noel's exactly right. How it reads to me is, I mean, I don't understand the testing procedures or policies. I'm pretty sure dispensaries don't know how it's done. So it's really an inspection issue to make sure when they come that you're in compliance. So I think that Noel's right. Maybe that's why.
And you have another one, I know, so I'm going to.
One more, section 1200, operation of registered facilities. Now it's subsection B, this is on page 16. Consumption, ingestion, inhalation, or topical application of usable marijuana anywhere on the premises of the registered facility. I recommend deleting 11 words, deleting that an employee of a registered facility who is, and then during their work shift, so that it reads that, consumption of usable marijuana is not allowed anywhere on the premises except that a patient may consume usable marijuana as necessary for his or her medical condition in a closed room, not visible to the public or other patients or caregivers acquiring medical marijuana, basically. We have over 1,400 patients with seizures, over 2,500 cancer patients, over 1,000 with the wasting syndrome, thousands with severe nausea, nearing 1,000 with HIV or AIDS, who live in subsidized housing, who have no other place to use, and we can have patients suffering seizures because they're not allowed to use their medicine in time, when a facility owner could prevent that by allowing medical use behind closed doors where no one else could see it. And to me, that takes into account, the balancing between keeping it medical, protecting the patients, and nobody wants, a backlash from voters of the federal government. It seems to me this strikes a proper balance to meet what's necessary for both patients and the Oregon Health Authority.
Yeah, let me ask Noel, because you run the facility. And maybe you can't answer this. My concern was what I heard last time from somebody who said, geez, we have potlucks, we have a pool table, we have fill in the blank. That to me is a club and is not a dispensary and ought not to be connected. What you're suggesting is a closed room that a patient goes into and medicates and then effectively leaves or soon thereafter. So my question to Noel is, if you've got 20 patients lined up, do you need 20 rooms? Or can you have more than one patient in the room? And if you have more than one patient in the room, so the next thing is, well, we'll put a TV in the room. The next thing is, well, they all want to watch TV, so we put a pool table in the room, and I'm right back to what I think is the problem.
Yeah, I would think language could be included to say that's not allowed, that multiple people gathering, to have entertainment within the room is not allowed, but a private room away from other patients could be accepted.
Now, our personal policy and procedure doesn't allow medication on site. A lot of our patients are very ill and shouldn't be around smoke and things like that. That's just our business's policy and procedure. But there's a lot of great clubs with dispensaries and a lot of great dispensaries with club rooms. And it seems like you can create rules that allow for that. I know it doesn't feel like your scope, but I'm not against Anthony's assertion that if an employee of a medical marijuana facility who was registered to use medical marijuana could medicate in a room at that facility, they're a patient. Just like any other patient, why should they be given extra rights or rights be taken away from those that enjoy them now? If a facility that passes muster chooses to have a club room that meets the out of public eye definition, it doesn't seem out of scope. It seems.
How long, I will admit that I don't know enough about this business, but how long does a typical patient need to medicate? I mean, are we talking 15 minutes in a closed room, or is this 2 hours in a closed room?
At most 15 minutes, but could be as little as 5.
And then what? Then they leave, and then what? Because I don't understand this either. So they have to come back in like a half hour, or the next day? How often does this happen? I mean, if you feel that they need to medicate in this facility, they're going to have to leave, right? And that the stuff's going to wear off. Generally speaking, when are they going to need to get high again? And does that mean they come back to the facility and go back into this room and medicate again? Is that like 3 times a day, or 5 or 10, or I have no idea.
Sure, it varies. I know a lot of these clubs, Sheriff, are quite social, and people will stay there half the day or play bingo or Texas Hold'em. They'll be there for hours.
But I mean, if, you know, given the model of just coming and getting your medication and going back to just a private room, using, you know, medicating, and then presumably leaving because you don't have the pool tables and the TVs, how long before they, you know, like when you go to a pharmacy, they say take one every 4 hours type thing. How does this work with marijuana?
I think from medicinal need, if a patient lives like in federal housing and there's a dispensary in their neighborhood and they have to go, you know, and if they have a high need, then they could be back, you know, every 4 hours or so. But that probably won't be the majority. There may be somebody who, you know, has a half-day meeting in Salem, and they need to, you know, go over to Noel's place to medicate, you know, on their lunch break to get back to their meeting, and then they go back to their, you know, home in, you know, wherever.
But there's hours, right, of the business? You'll be closed at some point. So if you're closed like after 11 p.m., where are these people in federal housing and they medicate?
Yeah, I mean, they could go someplace else, they maybe go without, but and to clarify, it's not about patients needing a place to get high, it's about patients using their medicine for their medical condition. A patient using a CBD glycerin tincture to prevent their seizures, they're not getting high. And for some patients, it could be once a day, it could be 3 times a day, and just because from midnight to 8 a.m. they don't have a place to go doesn't mean they shouldn't have a place to go to improve their quality of life during the day.
If I could, just being on both sides of the situation here, one thing coming back to the actual medical marijuana facilities and the person responsible for the facility, the owner or the manager, one of the things talking to a lot of the landlords and a lot of the lease spaces now is the smell of cannabis, whether consumed smoking or just the fresh smell of cannabis. And talking to a lot of the associations and some involved, one of their principal concerns is if there is consumption within a facility, how is that going to affect the other tenants? And let's face it, when you walk into a facility or a dispensary where there is no consumption on premise, the odor is going to be at a minimal level compared to one that has on-site consumption. Now, I understand the reasons for needing a place to go, but I think it was brought up before in the Rules Committee, and I thought it was a good idea, and it has been accepted by others in the regulatory model, is if you really want a safe room or a area where you can consume, it needs to have a physical different address than the actual medical marijuana facility or dispensary has. It's not saying you can't have it next door or around the corner, but I think truly for perception all the way to the use and the safety of the patient, it needs to have a physical separation from the medical marijuana facility itself to a safe environment where it can be consumed, medication taken, monitored, and so forth. I just think the biggest hurdle trying to jump is this combination of putting the two environments together. And by separating them with a physical address, you have a registered facility at this address, and yet you still have a safe area where people can take their medicine and be monitored and what have you, but it would need to be a different physical address.
You know, Paul, you raised another issue that at some point I saw some communications about, and that is whether a room where somebody medicates needs to have ventilation, and whether the ventilation needs to meet certain standards. And I don't know would a, at least in the old days, I'm not sure it's still legal anymore, but there used to be in California, I know, you could put in a venting system for a while in the back room of a bar, and you could smoke back there because whatever the venting system did purified the air enough to where would meet the EPA standards down there. Is that something that would address the landlord issue?
Well, I think a lot of the landlords and the real estate commission, outside of the worries of the federal government coming and seizing property, but under state law on that, one of their thing is, if I have a building and I've got 3 tenants in there, and I bring in a new medical marijuana facility as the 4th tenant, actually written into the clause now and talking to a lot of them are that there's no consumption on premise for that reason.
And most dispensaries currently have carbon air filtration, even just to get rid of the odor of the marijuana that's stored or on display there. And it's very effective for that. And with the proper the proper air exchange, that can be very effective for removing smoke or vapor too, without the odor leaving the facility.
And I think that can happen depending on how the business owner wants to run it or not, and that can set the stage for the environment that's there or not. But I agree with Paul for all the reasons he articulated. I won't repeat it. I strongly agree with Paul that if we're going to have these places where consumption is allowed, it should be separate and apart from the dispensary facility. So if we want a pharmacy and we want to have a pharmacy next to a club, that's fine. But the pharmacy isn't the club isn't the pharmacy. Maybe the owner owns both of them, but they're 2 different addresses. So people can go into the pharmacy, i.e. the dispensary, and not have it be a place where active usage is wafting into the place, whether they choose to have carbon filtration or not. I think there needs to be a separation for both political and patient safety and health reasons. These need to be separate. And so I support the language you have currently. That's just where I'm at.
If somebody's in a pharmacy and they need to take medication that would prevent their seizures, there's nothing in the law to prevent them from taking the medication to prevent their seizures. And the landlord issue, nothing in these rules would force a landlord to allow on-site consumption. So a landlord could always have their own policies about not allowing on-site consumption, and we could put limits on the number of people that could be in the room, or the fact that odor can't be wafted into the public area if that's a concern. It seems to me there's a way to protect patients that really need these facilities and still meet the standards that we need to meet. If somebody working there can use, then why can't a patient in subsidized housing that needs to use marijuana for their severe nausea or to prevent a seizure?
And I think we, again, kind of go back to that thing. An employee works for the facility. There are certain rules and regulations, whether it's a violation or what, but if I'm an employee, I have certain rights that the normal patient coming in does not have. Access to secured areas, the policies of the place, the alarm codes maybe, or so forth. So the deal that a patient should have the same rights as an employee to consume on premise, I don't buy, because the employee is employed by the facility. Again, it's not to complicate it, but the simplicity of having just a physical address that's separated from the facility. And I say that again, even with these filtration systems and knowing quite about just storing evidence in the past. Your carbon filtration system and how much volume it's going to move in that, we're not talking a couple $100s here. We're talking thousands of dollars. And when we heard the medical marijuana facilities before say a $4,000 fee for registration with OHA is outrageous, how many are really going to look at the price of a EPA standard filtration system, so you could have a private room for those patients that need to consume? Again, the economics are there.
I got to address one more thing. Nor do I accept the analogy comparing to the pharmacy. I go to a pharmacy and I pick up my hydrocodone pill or my penicillin pill. I don't go into a social room attached to the pharmacy and smoke it.
We're not talking about a social room.
Oh, I understand, but even a room. I don't go smoke the penicillin in a room that's separate, even filtered, when I'm in my pharmacy. So I don't accept the analogy, because we're asking essentially patients to be subjected to an environment that has smoke that has essentially not a medical, we're just asking, you're asking for something that isn't a medical facility.
Well, I think we're assuming that, again, I have absolutely no dog in this fight, just like testing. But I mean, I do think, and so I've tried to stay out of this conversation, but I mean, that is not the only way to consume marijuana. I mean, we're talking about eating it, we're talking about putting it in a vaporizer where you have, I mean, I smoke an electronic cigarette, it has no smell, it has no nothing, it comes out, sometimes you just hold it in long enough and nothing comes out. I mean, so I think there are a lot of ways to take your medicine. And so I think kind of pegging it into just the combustion role is not really, I mean, if we're arguing against the analogy, the premise is wrong. So there are a lot of ways. So I mean, if the real issue is we're trying to protect people from smoke, from combustion, then that's separate from consumption. So I think that, you know, that seems to be the issue. So I don't see why regulating somebody, you know, sucking on their Jolly Rancher is the same thing as saying you need to follow the general rules about indoor smoke. So I just want to be clear. I mean, everybody here knows there are different ways to consume it, but it does seem to be a little far-reaching to assume everyone's, you know, lighting up their bowl in the pharmacy. So.
Okay.
This is topical application. I mean, topical application. How is that harming anybody else? How is that bringing up an issue that this isn't like a pharmacy or a medical establishment?
I got it. Don't know where we're going to end up, but you guys are advising, and I've been advised, and I understand it. Jack, do you have any issues here that you want to bring? Yeah.
Is it just on testing or?
No. This is free for all.
Well, just on testing, and I'm not trying to be a scientist or a lawyer, but on page 2, at the very bottom, when you talk about mitigate any pest, and that includes any of the following, and then you list the 20, I guess, with the pesticides.
Right.
Unless this group here actually knows that those are the only pesticides, I would just suggest that you say but not limited to, or just in case there's something else, but that's just it.
Yeah, I don't like the list, but I'm having real problems. One choice is to just say pesticides, and then we're testing for 12,000 different pesticides. So the thought was to try and find, and I spent a lot of time talking to people who grow, and these are the common pesticides that are used on the plants that will metabolize and disappear into the system if it's done right.
Okay.
And so that's why this list was, I don't guarantee this list is the right list or the wrong list. Including but not limited to may help. I suspect this list and this whole testing thing is going to evolve over time, but
Okay.
point taken.
And then, you know, you talk a lot about patient safety, and I know that was the governor's charge, and it's your charge, and what, and I think that's good. But I also, I think last meeting, a lady from the public got up, and she basically challenged all of us, ask us how many of us had visited a dispensary. And I thought her point was well taken, so I took it upon myself to go visit one.
In uniform?
No, I gave him my card.
Okay.
He promptly showed me the door. No, he was very nice. He showed me through the facility. So patient safety is good, but I have to go on record voicing my concern about public safety on what I saw. What I saw was when I went into a sort of this foyer that there's nothing there, and then there's another door that you go in, and that's where the marijuana was. But from a public safety standpoint, I had some very serious concerns immediately when I went in there. And right on the counter was, I'm not trying to be critical of the store, because I don't think they're doing anything intentionally. But what I saw was right on the counter, and I realize children will not be in there, but right on the counter were these gummy bears. And these are soaked with whatever it is that they put in, you know, THC or whatever. And then I looked back and I saw caramel popcorn. So first thing that goes through my mind is, okay, patient safety, that's fine. What about when this product gets to a home where there's children? I don't know a kid that would not reach up and grab a brightly colored orange, red purple, green gummy bear and stick it in their mouth. And I think that's a concern. I think we can teach our kids not to smoke pot, perhaps, the little ones. But I don't know how we're going to, how we're going to teach our kids when you go to the neighbor's house, be careful not to eat a piece of candy. Or if you see some popcorn on the table, don't eat it. Those are some concerns that I have, because those are really disguised to what I think is a very dangerous, it's very dangerous disguise for young kids. So I asked the dispensary owner, I said, for example, the popcorn, caramel popcorn, how much is in that? I mean, how much THC is in this? So how do you, when you give it to a patient, how do they know what it's going to do to them? And basically his response was, and keep in mind, from what I hear is whatever it is that's in marijuana, it sort of stimulates your hunger, or it can. And he said basically what we suggest people do is eat this caramel popcorn until they feel that they've had enough. And maybe I've watched too much Cheech and Chong, where they're, just want to eat copious amounts of food when they get high. But I thought that seemed a little odd to have a food product that the only way you're going to know when you're medicated is to eat this stuff until you get to a certain point. I'm not a scientist, I'm not a doctor, but I wonder if that's really a wise way of measuring something while at the same time your hunger is being stimulated.
You asked two questions there, and so let me take the last one first. Unfortunately, the issue of how much you need to consume is not controlled by a doctor. And until we reach that stage, I don't know that we can get to what we want. I am told that every person's need to medicate is unique. And unlike a pill where the doctor says take one a day for the next 30 days, there's been testing to know that in fact does deliver for 95% of the population the amount of medicine that needs. That hasn't been done in this business. And so right now the doctors are saying, if you have a problem, go take it, and you figure out how much you need to consume. So
basically just move the caramel popcorn to the side and then start eating something else.
Yeah, and I don't have, unfortunately the answer. The gummy bear issue does concern me, and I think it's something that we may want to look at. Had you were actually inside the dispensary where they were handing out the product. So this was, so this is not something that the consumer could see, just happens to walk in the door.
A consumer could not see that, but if the consumer takes that product home.
Yeah. So we do have the requirement on page 18 that says, warning, medical product, keep out of reach of children, and that would be on the package of gummy bear.
Okay, but when I go to the pharmacy, I get a pill bottle, and it has a child-proof lock on it.
Yeah.
These run little baggies. So you're going to go home. There's really no safe way to. I mean, it'd be nice if everybody was responsible with the medication and not put it in reach of children. But there's a reason why they put those tamper-proof lids on pills, because we know everybody's not responsible. So we put something in between a small kid and medication. But like I say, it's so. I mean, there's not anybody in this room that hasn't seen a gummy bear, and I think we've all would be tempted to, when we see them, they're enticing. We want to eat them, especially for a small kid. I just
Piece of chocolate for me, but
I love gummy bears.
yeah.
And I walk by and steal them all from a neighbor's house whenever I see them.
Yeah, and the popcorn story was just more of a sort of a, not as big a concern, but when they start masking this and, I mean, not masking it, but putting it in a substance that is known, that I think we could all agree is geared toward children. I don't think that's safe.
I think this raises an issue that goes on my, we need to clarify a law of business, because I think your point is very well taken. I think we need to figure out, and maybe the industry needs to start doing it on their own, figure out how to self-regulate on their product. And something that looks like a gummy bear or an M&M or a lemon drop or whatever it is, maybe they need to start.
Well, but here's my issue with that, Tom. If we didn't regulate the tobacco industry and the alcohol industry, and dare say the pharmaceutical industry, would they not be marketing to kids.
Oh, yeah, yeah. Well, and that's
And
right.
so I think it's naive to assume that this industry, as it develops and grows and becomes a major industry, will self-regulate so it doesn't market to kids.
Well, and that's my point, is we may need a law change in order to help with that.
I agree.
Yeah, and it goes on my list.
Because I don't think the industry is going to do it themselves. Not that I'm blaming the industry, because the pharmaceutical industry would do it, has done it. And the alcohol industry has done it. So, I mean,
the difference between the cannabis industry and other industries is that the cannabis industry realizes that we got to keep off the federal radar or the whole industry goes away. And so it is within our interest to self-regulate and to make sure cannabis stays out of the hands of children. As far as what can cannabis be in, I think that's a statutory change that would have to be done. I think it's outside the scope of this.
I appreciate what you're saying, but I saw gummy bears, so they're not being careful with it.
Yeah.
So I mean, this is
I
something.
mean, not that places can be improved, but you went to one place, and over time, as the industry develops, I mean, these
I
are
do
regulations
think though,
that
Jack,
are needed.
it is clearly a failure in the law that doesn't address the whole kids issue, and I think that's something that needs to go on the agenda for 2015.
Okay. And then one last thing that will probably not go over well with the group, but this medicine, the term medicine, maybe I'm taking it too serious, but if I'm not, I just have some concerns about an employee who's dispensing medicine being impaired. I mean, maybe it's just the nature of my business that we don't allow that, but it just seems, I mean, I think, assuming we all agree that being under the influence of marijuana is impaired, that's why you can't drive under the influence of marijuana. It seems like if we're dispensing medicine to the public, to patients, do we really want people that are passing out medication to be impaired? That seems odd to me.
It's definitely the duty of the employer not to have impaired workforce. And I think part of people's misconception is when people use medically how impaired they actually get. Nobody on any job get to use painkillers if they've gotten out of surgery.
How about marijuana? That's what I'm talking about.
But if they have a medical card for medical condition, it's how they're impaired is much different than the normal person who's, like you said earlier, like getting high. Getting high is different than somebody who's using medically. And I think that's something that a lot of people who don't have much experience with patients don't quite understand.
I've been thinking about how, like, real life law applies to the marijuana industry recently, pretty seriously. And I mean, my feeling is that there are lots of laws out there, and there's a whole field of law, like employment law, that deals with people on the job using marijuana, using other medications. I just feel like we're trying to kind of make marijuana so different from like a real business that it becomes its own unique entity with no guidance. So there's plenty of employment law out there that deals with people using marijuana while they're working and what an employer can do about that. So I want this to look like a real business and like any other business and not like its own unique thing that we're trying to start from ground zero. So my feeling is the employment law area, and there are plenty of employment lawyers, they should deal with that. There's a whole, they've been litigating this issue for a long time. So I don't know that we need like something special to deal with marijuana. What applies to every other employee through years of case law should apply here, just like for anything else to do with marijuana. There's plenty of law out there.
But we have it in here that says you can. And I don't know that when we like to compare with, like, do you require other people to do that? I don't know, and I'm speaking out of turn here, but I don't know if our pharmacist is allowed to go back in the back room and smoke pot under every so many hours and they come out and dispense medication. Is that allowable?
But there are plenty of pharmacy and every other employee out there who take their Xanax before they go to work, or who take their well, if we're saying this is a type of medication.
I don't know.
Maybe.
Okay, that's just a question.
But I think the whole issue of impairment is vastly different. And I think the reason we have the exception for employees in here is because we're saying no consumption on premises except for employees. That's why it's in here. So, and
It's just a concern.
really,
I'm just on record. I don't think we can argue it all day, but I don't want somebody dispensing medicine to somebody in my family that's maybe inherited, that's all. And I think we're making an accommodation that makes that more likely to happen. I'm not saying that necessarily they are, but I think we're making an exception to accommodate the
Now,
likelihood.
are the employees going to be?
Hang on one second. Who joined us on the phone?
Tom, this is Gary Snobble. I finally made it on
Okay,
for the Board of Pharmacy.
Thanks, Gary. I just wanted to, you're listening and we can hear you.
So my question
Okay,
is,
perfect, thanks.
I understand we're allowing employees to use medically on premises in a separate room. Are we talking about how they're going to use and then whether it's ventilated, or, I mean, if they're going to be smoking, for example, don't the other, I understand the point, and even for the labor law lawyers, but I mean, if it's not adequately ventilated, and if they're going to a break room, for example, the other employees are going to be exposed to this smoke, and I mean, we don't allow in normal employment context that to occur under the Clean Air Act right now. I mean, employees have rights to not have secondhand smoke. And I would assume that employees of these facilities would have those same rights. Right?
The Indoor Clean Air Act.
Point, right?
Yes.
Yep.
The Indoor Clean Air Act, though, it applies to tobacco, not.
I know, and that's my issue. We are treating this differently, so why are we allowing employees to smoke on premises and expose other employees to secondhand smoke?
Because there's no harm from secondhand cannabis smoke.
I'm sorry.
There's no harm from secondhand cannabis smoke.
But as an employee, don't I have a right to not be subjected to it?
So that's a labor law issue. So in that circumstance, I mean, again, we're talking, can you tell me what page we're on? I asked down here, but nobody's sure what page we're looking at.
We're off page.
Okay. That's what I thought. I mean, that's when labor law kicks in. If I feel that I'm in a work environment that is dangerous or hostile, I have avenues through OLI, through other agencies to address that. So I don't want to recreate the wheel. I think it's inappropriate and ineffective, and it puts us in dangerous territory. So if you're in an environment where an employer allows that, there are avenues to address that through labor law. So let it be addressed through labor law.
And that's fine. That's fine. I'm just expressing a concern.
To correct the issue about employees being the patient instead of employees.
Jack, any other issues?
No.
Yeah, okay. I'll go to the other end. Amy, I know, I'm afraid of you. Amy, you got any issues you want to raise?
I was just turning to page 16 because that's where that's where the other issue was. Again, I'm not sure if I have lots of issues, but I realize we're at the end of this process, and I don't want to muddy the water anymore. I mean, some of this needs to be sussed out in 2000 special session in 2015 and other places. But my biggest concern, and I don't want to spark another long conversation about testing, is that I'm always worried when you put into rules so much detail about stuff that is sort of an ever-changing science. I think that the testing people worked really hard on this and that it was painful in lots of ways. But, you know, I worry not about kind of the over-regulation issue, but about sort of a constantly and quickly changing science. And so in order to come back and change the rules, it just concerns me.
Well, didn't I tell you that you're all volunteering to start next week on a whole new set of rules for this?
Yeah, I mean, I don't know. It just seems to me that this is very, very specific, like has quality system for testing of pesticides that meets these particular sort of standards. And
Yeah, so here's the logic, and I don't see any testers in the room. Maybe there are, I don't know. But here was the logic. The law doesn't allow us to get the testers, and the law doesn't allow us to get the growers, except by defining the product that comes in and the work product that a lab does. So that's one of the reasons why this is in here. What I would hope for is that both the grower community and the lab community step forward with a piece of legislation in 2015 that self-regulates this, so that a lot of this stuff can go away and we don't have to sort of try and be as prescriptive in here as we ended up being, in order to try and reach where there's some question about how far, you know, what can we really, we can't do what we need to do. I mean, if we had the ideal world, we'd say, you know, every grower is going to be a 100% pesticide-free product, and you're going to be in a sterile environment, and you know, we won't need to do a pesticide test. But I can't force that on the growers, so I have to go at it from another way.
And I think that that's a really valid point specifically to kind of the rulemaking process, is to introduce some sort of legislation that will preempt the rules in this document. On the off chance that doesn't happen, I think that being so specific has the potential to be problematic. And again, I don't fully understand all of this, but if somebody doesn't do that, I think we'll run up against the problem in a very, very short period of time.
And we have, I mean, there's a mechanism that is in place for a temporary rule change that can address that. So, like I said, you were all volunteering.
And I mean, I have some other issues. I wasn't. Can you come back to me next? I just want to make sure I get my thoughts on it.
Well, Noel, you want to comment? You have any issues that you want to raise? And by the way, as you're looking at this, please do not stop at just rules, because a couple of you may want to look at the forms.
That's actually what I wanted to propose. From a matter of practicality is not the best word, but to require a patient to authorize a grower or caregiver to transfer usable medical marijuana to a facility each time is not terribly tenable.
It's not each time.
No.
Once
One
this form
time.
is filled out,
Per facility.
So it's kind of a standing order.
it's a
Yeah.
standing
All
order.
right,
Yeah.
all right. Now, when I read that, I didn't get that. It felt like this was something that would need to accompany each transfer order. So anything to
It
this.
expires on the date that the expires.
All right,
Unless it's indicated.
all right. That's
So
fine.
one-
I was just
1
gonna,
year.
I was just gonna, you know, offer up to the committee for review a kind of parent-child document thing where the authorization was given up front, and then there was a transfer order for each transfer, and that was bifurcated into whether or not it was organic or concentrates, secondary production stuff. All right.
We may need that in the future, but right now.
No, but I'm really not about overcomplicating things. I just want to
Once this is in
find
place,
something
it
that's
lasts.
tenable, and that's fine.
Anything else, Noel?
No, I would just support leaving the employee usage language as it is. If we can't find anything that the majority agrees would be banned.
Okay, I'm going to go and face Rob. What issue? I mean, that's in front of us here.
I think we've already discussed them, so I won't extend your list. Most of my punch list items and my struggles and my frustrations have to do with the legislation itself. And it don't have to do with our process here. I think everybody here on this committee has done a really good job at distilling out what we can within the parameters of our authority. I would just, on one final point that was just made, I don't have a problem with the language that you worked on for employees, but I would strongly urge you to consider whether or not smoking should be something that's allowed unless there is truly adequate ventilation that essentially gives the other employees the right to be free from secondhand smoke. I don't know what language you come up with, but I would urge you to consider that.
Paul?
Yeah. Mine were already incorporated, so
Okay.
I'm fine.
Okay.
Should go with him first.
So, I think I only have one issue left, and I want to thank the agency right now and Shannon for doing some really good work on this over the last several months. We've added a definition of employee in here, and we do have situations where dispensaries are registered as nonprofit entities, and volunteers are actually in their shops and in a sense working there. And what I want to make sure is that we're not necessarily doing anything that's going to disallow the use of volunteers in those situations. And wondering, as a second question, is if we were going to keep the language that allows employees to medicate on premises, would that also, that same coverage be extended potentially to volunteers in a nonprofit setting?
Well, then everybody becomes a volunteer.
No,
I mean, literally,
not
everybody becomes a volunteer.
No, I mean, there are people who work in places as volunteers and they're behind the counter, and that's different than a person who walks in and says, I'm here to be a patient.
I understand.
So there is a difference between a volunteer and somebody who just walks in the store.
I understand, but you didn't get my point. My point is that if I'm operating one of these facilities and I want to have essentially a room where everybody can smoke marijuana, I get around the rule by making every one of my customers a volunteer.
We can get around a lot of rules. Can I ask Shannon to answer that question specifically as to whether or not we're not allowing volunteers to be, working in these facilities, and whether or not those protections extend to that?
So the reason the employee issue came up was 3460 only protects employees of facilities from various criminal laws related to marijuana. So, the rules talk about what employees of facilities can do and not do. I mean, I took a definition of employee that already essentially existed in state law. I mean, I think it stretches it to say that a volunteer is going to be considered an employee, but it may depend on how they're being compensated, right?
Well, the definition of a volunteer through employment is you can't have prearranged compensation, otherwise they're an employee or a contractor. So there's a lot of people that, are on full-time permanent disability, and so they like to get out, they like the culture, they like interacting with people, but obviously their disability prevents them from being completely reliable about that. So, they're a volunteer. You have to be a nonprofit organization to have volunteers providing services in your place. Otherwise, you're violating a different set of employment laws. That's employee theft, or tax theft, or something like that.
But that's the rub. 3460 it just refers to employees, not to volunteers.
Right, so could we expand the definition of employees to include on-duty volunteers, I believe is the question.
That's outside the scope of our parameters. We're stuck with the law. If we can't fix all the other problems with 3460, how can we fix that problem with 3460 and rule?
Just by defining what constitutes an employee in the spirit of the law.
In addition, we're requiring testing for potency that's not contained within the law, and we've all agreed to that because we think that's the right thing to do.
Because 3460 is silent on that. But 3460 is
Hey,
not.
Tom, this is Gary.
Yeah, Gary.
I'm looking at our new definition of employee that specifically excludes volunteers. We by rule excluded volunteers with new language.
Right.
On page 1.
And I think that's the issue, Gary, is there's a desire to maybe put that back in. It's about page 1, top of page 2. So I think, Shannon, the issue is if a volunteer is working in a facility, and somebody decides to do a raid for whatever reason, some law enforcement, the employees would be protected by 3460, but the volunteers would not. The way the rules and the way 3460. And what Jeff is asking for, with some input from Noel, is there a way to stretch the definition of employee to cover a volunteer? And I know we looked at the word employee, we had conversations about remuneration, I know Amy weighed in on what an employee was. This is the definition of the word employee that is in statute elsewhere and in rule elsewhere, and we have not changed that at all. And to stretch it, my word, to address the volunteer issue would really be pushing the envelope that is far broader than just whatever stretching we might have done in 3460. I don't want to, is that sort of a characterization of where we are?
Yes, I think so.
Are there any definitions in statute right now that do include volunteers as part of the definition of employee? Or, I would assume there's more than one definition.
And I'd throw
employee
intern in there as
statute.
well.
I don't know.
Okay.
Also, just want to, remind us about the spirit of the law too. The OMA has been, for the past 15 years, it's been, patient-centered. And there is a very strong history of patients helping each other, and nonprofits and volunteers, and there's a very strong spirit of that in Oregon, even compared to other states as well. And I don't want to see that lost here. I want to see the ability for this industry to grow, but I don't want to see, I don't want to lose out on patients helping each other. So perhaps a solution here, the definition includes or under any contract of hire. If we were able to delete the part that excludes volunteers, or qualify that with the volunteer being under a contract or under some sort of documentation, then that would hopefully satisfy, Rob's fear of the cops are showing up, everybody's all, just declaring everybody a volunteer. If there's some sort of documentation that they're a volunteer, could we work with that?
I second that in spirit.
I do too, but I think we're outside the scope of what 3460 allows us to do.
I disagree.
I mean, I think that there's a couple of things. One, I mean, DAs are not going to be bound by our definition of employee for purposes of deciding whether or not to criminally prosecute someone, I would presume. And so, my guess is that they would argue about the plain meaning of the word, et cetera. I mean, I suppose OHA could decide to stay out of this sort of altogether. We just need a way to talk about who is working at a facility and what those people can do and not do. I mean, using the word employee, when you're talking about who has to accompany patients in the areas where there's marijuana, et cetera. I mean, we just need a way to talk about who that person is. So, I don't know, maybe Tom and I probably need to get together and talk about this more.
And I can tell you that from the time we wrote the original OMA back in 1998 to working on 3460, there was no legislative or no intent at all to disallow people who want to volunteer under the circumstances that Noel described from being able to participate in this program.
Again, this is where to Amy's point, I mean, if you're saying that an employee in these medical marijuana facilities are really something other than what would be considered an employee in other contexts, are we creating these different rules for these facilities? And
if I entered into a contract with Noel to volunteer my services, would the contract language that is at the bottom of page 1 protect me? Any contract of hire, or because the word hire?
It would depend on what the contract for hire meant. I mean, if you're really an independent contractor, then you're not an employee. And
okay,
right,
that would be somebody who comes in to do maintenance or do janitorial services or that type of thing. But if I'm on contract to come in and literally work inside the facility, check people in or whatever it is, and I have a contract to do that for no remuneration, is that a contract that would protect them?
For no remuneration?
Yeah, I'm volunteering my time. I agree to work 30 hours a week for $0.
Well, maybe hire is the word in question here that we need to back away.
I mean, I'm not.
And just because you volunteer, you're an intern, doesn't mean you're not held to the same high standards as a paid employee. If you're working the front, you're checking cards, dates, IDs. I mean, there's no tolerance for slack there. So there is an employee handbook. There is training, food handlers cards to get. They're held to the same standard.
Well, we'll go back and check with labor law. I mean, again, recognizing the purpose of this was to make sure that we are protecting everybody who's working inside. Because you can work inside without an OMP card. So you're working without the general OMP protections that everybody can function under. And we don't want your employees, however broadly you choose to define it, to be at risk. And that was the reason why we worked so hard for this. But
right.
And also in the nonprofit world, it's been growing more towards volunteers being somewhat equal to employees in terms of liabilities and responsibilities and such. And I recall even the Department of Justice Charitable Activities Division also uses language like that. So could you talk with your colleagues in the Charitable Activities Division to see how we can protect volunteers under here?
All right, Amy, what did I say wrong?
No, you didn't say that. I'm concerned because I don't think that this is, so employee, I agree, has a very specific definition. I think it has very specific tax consequences dependent on the incorporation of the business. I am concerned that this doesn't apply to contractors. That is, a contractor is not an employee and an employee is not a contractor. Somebody who's getting a 1099 is not defined as an employee, and if they are defined as an employee, they have to pay employment tax. There are some real problems. So, and I think we've kind of talked about them a little, so I do want to be, if we're talking about volunteers, I think we should also be talking about 1099 contractors, and I think it's super dangerous for a dispensary to call a contractor an employee if they're, because there are already tangles in terms of the tax issue. So that is something I think needs to be addressed. In fact, I'm more concerned about that than the volunteer issue, because the volunteer issue, you could at least say, I'm not paying them an employment tax on them or health benefits or any sort of payroll withholdings because they're volunteering.
We do still have to cover them with work comp though.
Yeah, and I think that's a really good point too.
So there might be language over in the work comp area that helps.
But it will never make them an employee, just like it will never make a 1099 receiver anything other than a contractor.
But let me tell you why I'm not concerned about that. Because I think the independent contractors and contractors that are going to work for these facilities aren't going to be the dispensers. They're not going to need the legal protection. They're going to be the ones hired to do security. They're going to be the ones hired to do construction. They're going to be the ones hired to do all the things the businesses hire people to do that aren't employees. They're not going to be the ones working the counter dispensing the drugs, so they won't need the protection. The people that need the protection are the employees that are actually doing the dispensing that violates federal law.
And that may very well be, and I'm thinking about the security guard,
Right.
right, who is there 40 hours a week. He is a contractor, but he is at the facility 40 hours a week. He takes his break at the break room, or she takes her break at the break room, and she looks, or he looks like somebody who's present at the facility.
Well, Amy, if you look on page 16, in the middle of the page 3D, it does allow a contractor authorized by the PRF to be on the premises. So,
I think Amy's concern is that maybe some creative prosecutor might argue, I don't know what it would be.
That they're in possession of all the marijuana on
Yeah,
the
I
premises,
just-
because
I don't
I know
think-
there's nothing we can do about that.
I know, and there's nothing you can do about that because it's, again, it's back to 3460, which just protects the employee, doesn't protect independent contractors. But I just don't see that being a problem. I don't think it's going to be a problem.
Can I talk about one other thing that popped out to me, because I have trial this afternoon, so I'm gonna have to leave early.
We're ending at noon.
Yeah.
Yeah.
I have a concern on page 6 of 30. I mean, we all know there are a number of dispensaries currently operating. This talks about, and it's not anything we've ever really talked about, but it's 6B, and it's sort of, I think, and again, I don't know if anyone will prosecute anyone for it, but it says, the provisionally registered facility may not receive transfers of usable marijuana or immature plants, or transfer usable marijuana or immature plants until the security system are in place and the authority has approved the provisionally registered facility to begin operating. I am concerned that that language, which is may not, will put the dispensaries who are operating, have applied, have not received the provisional license yet. I don't know what the time period will be, that there will actually maybe, it sounds like almost a blackout period.
Yes.
Am I reading that correctly?
That's how it's written.
So and I know that's not language anyone's touched yet, it's not in red, but it does seem to create an affirmative blackout period for receiving, like, things being
Well,
stopped.
so here's my problem.
Okay.
There are no facilities functioning today, as far as OHA is concerned.
Right.
So I get an application. If that application has a security system, because the facility has already built that security system, there's no issue. If the application does not have a security system, what I want to do is say, because of the cost necessary to build a security system, and build the vaults, and build the safes, and build all that stuff. I'm saying, we're giving you, go ahead, expend those resources, and expend the time necessary to do that. But you can't receive product, and you can't dispense product until that's in place.
But I don't, I'm nitpicking this. But I read it, the and that's in there. So it doesn't sound to me like all the authority is looking at is the security system to issue a provisional license. And maybe I'm misreading it, but what you're telling me that if you get an application, it says we already have the security system in place, there will be an immediate issuance of a provisional license without looking at any of the other factors?
As immediate as we can want, we're going to do the background check, we're going to do the all the other checks that are required in here, the 1,000 feet checks and all those things. But at some point, and they have a security system that meets the requirements of here, then we're going to say, here's your license, go do good.
So should we be advising clients, I guess it's my question in terms of criminal defense law, so should I be advising clients that they should not be, and maybe this question for Rob, because I'm sure this is a prosecutorial issue and not really, I guess, an OHA issue, but it does sound like there is now an affirmative you may not, and I don't know if it will take a week or 2 weeks. I'm not sure we have any sense how many applications will come in for those 4 people to look at. So I mean, it's not, maybe it takes 3 weeks to get a provisional license.
Shannon,
So this was put in here so that facilities could apply and wait to know that they're going to be registered, and then install the expensive security system later. Right? That's why this provisional thing is in there, so that you're not, expending a bunch of money to put in a security system if you're not actually going to be registered because you're within 1,000 feet of another facility or whatever. If you have everything in place according to the rules, then you're not going to get a provisional registration, you're going to get registered.
And how long do we anticipate that taking from the time of application? Because do you think I'm reading it wrong? I'm open to hearing that I'm reading it wrong, but to me it says until you either receive your provisional license, provisional registration, or your actual registration, you may not receive transfers.
Right.
So how long do you think that will take?
I can't answer that. It's not.
Yeah.
I just don't know the answer.
I think actually some in our audience here today asked the same question. Come March 1st, since it's a Saturday, and you can't put in your application till Monday the 3rd, do we have to shut down on Saturday the 1st, and are we in violation of the rules now, which take effect March 1st? Or now are we in this gray area and in violation of the rules until we receive our official registration with our unique number from OHA? And it's a gray area.
Does submission of a completed application, payment, and all the required attachments constitute an affirmative defense, just like a signed doctor's thing and the application and the fee does to
It
patients?
doesn't say that anywhere, and it's
Not
not
in
what
No,
6B says.
and I think we're back to that gray area. The best thing to say is a complete gray area. But I would say, Rob, or any, speaking for the sheriff and law enforcement, that you're not going to waste your resources and turn them against a medical marijuana facility on Saturday, March 1st, or on Sunday, or on Monday, or within a short period of time. And even if we came, i.e. as a law enforcement entity, to check and verify, and as Noel just said, here's my application submitted, a copy of our certified check submitted, we are in the process waiting. I don't believe in good conscience you're going to use your resources to go after an individual or a business during a gray period like this.
And again, before we go back, again, it was, I am a new facility, and I want to open 527 Main. And you've now put all these, I want to sign a lease, and I want to meet the requirements, but there's a huge cost up front, and I don't know whether 527 Main is going to be an acceptable address. So what we said was, fine, we'll accept your application and say provisionally, you have passed the background check, you have passed the distance check and all that. Go ahead and in 527, build out. And while you're building out, you can't accept anything. And until you're built, well, you can't accept anything product until you're built out.
So I guess that.
So this was aimed at brand new facilities that want to know, and I suppose any other facility that wants to know whether they're going to work or not.
So, and I think that raises, so I don't think that's what it says. That's not how I read it. And maybe we should just trust law enforcement, but that's not the advice I give my clients. No offense. But so I think that there's a way to modify the language in that to actually read that. I think that brings up the interesting point, which is that under this model, pre-existing facilities are not guaranteed to receive a registration or a license at all. So let's say you are dispensary X, you are pre-existing, you have no idea that another dispensary got their application in first, you are continuing to, I see as direct violation of 6B, that you are continuing to operate. Are you, one, how do you know that somebody else has submitted and has beat you there? And two, are you now operating completely unlawfully? I mean, right now maybe it's a gray area, but I don't think this makes it a gray area at all. It says you may not.
But it's modified by if the proposed facility appears to be in compliance with 314.
Where do you?
And what B is under. Go up to read 6.
Mm-hmm.
Go up and read 6. If the proposed facility appears to be in compliance with 314 and these rules, except that the proposed facility does not have a security system installed or has a security requirement, the authority may issue.
But
I think I have a very easy fix to this. If we change the language in B, if we remove the language that says may not receive transfer of usable marijuana or immature plants or transfer of that clause there, and substitute something like a provisionally registered facility may not receive a final license or a final registration until that's been done. Because then you're tying it from the provisional to the final as opposed to.
So you're saying go off and rent 527, submit an application, and immediately start accepting plans before I've even looked at it, before the security system in place, before any of the stuff that is required in here?
All I'm saying is that you can't receive your final license until that's
but in the meantime,
But in the meantime, there are somewhere between 150 and 200 facilities who are operating right now today and will continue to operate until they get their final license. And I know that's not your issue, but it still reflects the reality of what's going on out there today, and it doesn't tie it to the incoming or that transfer of marijuana in or out. It ties it to being able to receive the final license once the security system is in place and is inspected.
I guess my question is a fairly simple question, and I just read it differently. Do we believe on this committee that while you are pending whether you are operating or not, while you are pending your provisional license, that you are allowed to receive a transfer of marijuana into your facility?
What do you mean by allowed? Allowed by the authority or accepting some criminal
Just,
laws if you do?
Well, I mean, are you prohibited by rule based on how this is drafted from receiving usable marijuana into your facility until you have your provisional license?
I think so, but I think you are right now.
I think that's law, isn't that what 3460 says?
So I think what we're transitioning, I know, I see you're struggling, but we're transitioning from black to gray to white or whatever, for lack of a better way to characterize it. In that gray area, I just can't see my colleagues getting wrapped up around prosecuting someone when they're in the gray area if they're not prosecuting them when they're in the black area.
I just don't want people to use it as an excuse. So I mean, that's how I see it very differently. And I'm going to pull back from this issue. I understand where everyone's at. I don't want to waste more time. But I just don't, I see these things used as sort of an excuse to go do a raid instead of like.
They can do it now.
Yeah, absolutely. I agree with you.
Then there's no protection at all.
Yeah.
And so in some counties that's occurring, in other counties it's not.
Yeah, I see it a little different than Amy. I'd see this more as a OHA issue versus a prosecutorial issue, because prosecutors, if they so choose, could rate places now, and hopefully they choose not to, of course. I guess my question is, if somebody gets a provisional license, and then they say, okay, now we have our security system in place, you go to inspect, there are already plants there, are they going to be denied? Are they going to be denied the license because they?
Yeah, to be honest, in the first wave, I do not anticipate getting out to inspect until after everybody's been licensed. I just don't. We just don't have the staff to do that. I mean, I'd be happy to do that, but that means that it will be, if we get 100 licenses on the first day, it will be 2 years before we get them approved, because you can do about one of these a week.
And so they're just going to let you know, we now have a security system, and then at some point you may inspect.
Yeah.
And, my concern here is, of the 200 some dispensaries open right now, some are clearly legal, some of them are clearly illegal, but most of them are in the gray area. And they could continue operating until they get licensed, but I think with this rule, it's adding a rule that they could violate rather than being under the kind of existing gray area reimbursement statutes. And so I don't want to see there be this rule that they could violate easily.
But if they have that existing potential defense, nothing about this changes that.
Except that they could violate this rule by continuing to do business.
Right, but they still have, arguably, the gray area defense that they have right now, because nothing about 3460 took away anybody's arguable defenses to any other marijuana. It's not the way I read this.
Yeah, I mean, to me, the rule they could violate is the OHA could say, we got word, we have information to know that you were receiving marijuana, and so, well, you're subject to a civil penalty or
Administrative.
or we're going to inspect you more often. But to me, it's not a criminal issue. It's an OHA licensing issue.
And Shannon, can they actually violate the rule before they're licensed, or are they subject to the rules only after they've received their license?
I think that theoretically it might be a basis for denial if you knew somebody was violating, but I don't think that that's what is intended.
And besides that, also my concern is right now the dispensaries that are open, there are thousands, tens of thousands of patients that depend on those places for their supply of medicine, and if they have to shut down, and probably the most by the books, honest kind of dispensaries, will shut down for a time. That could create a public health issue, as well as a crime issue, because the patients that all of a sudden don't have access are going to go to the streets. And I don't think that's in turning down orders 8 points away.
But if we pull this out, then there won't be any way for somebody with a facility to essentially lock down their 2,000-foot radius, before they spend a lot of money on security.
Right. That's what I kept hearing. That's what everybody, we heard from multiple people saying, I get what you want us to do, but you're asking me to invest a lot of money in an address that I don't know because of the confidentiality rules and because of the first come, first served rule. I don't know whether it's worth my expenses. And this is a way for them to apply, to lock in their space, and then to go and do the build out.
I think there's just going to, it already is a risky business. Yeah. There's inherent risk about this entire business, and I think I don't think we can make this risk go away quicker without having people spend a lot of money up front.
Okay, you got another one? No. All right, your turn.
Very good.
Oh, I'm sorry, Paul, did you get it?
Yeah.
I did.
Okay.
I just want to make sure. And I haven't been putting you last, but I did.
Okay. First, the school things. The definitions of schools. I'm still very uncomfortable leaving it so fuzzy. And it was great when I found that I made the mistake that the Oregon Department of Education's directory actually does include private schools. And I thought, well, great, this is a very bright line. And of course, I got Rob's email, which always starts off with the same line.
Sorry.
Sorry. But we really need clear, bright lines here. And that's what I know law enforcement has been asking for all of these years, is clear, bright lines. And I mean, what kind of schools don't register with the state?
Any private school.
Any private school is not required to.
They're not required to.
So they can, and so that's the rub. I mean, we've struggled with that issue in criminal law forever, and I don't know how we give certainty to that in the context of these rules. I don't think we can, because 3460 mirrors the criminal law, and it's the way it's crafted, and so to the extent we have uncertainty with criminal law, you have uncertainty very good here, and I don't think we can fix it.
I wish there was a clear, bright line, and one of the things, this is on my tick list for 2015, which is we need to figure out how to address this issue in the private school world.
I mean, Chapter 475 and this bill doesn't say within 1,000 feet of a school registered with the, it doesn't say that.
But we have to define it. And I have one client who's got a school 986 feet away. They have a few schools or a few students registered, and they don't have a plan. They don't have funding for next year, and they're probably not going to exist next year, but they're going to exist till June.
Wait till July.
And so
that's the only answer. I mean,
I can't. Yeah, Todd. I get it. I absolutely get it. But it's poorly crafted legislation. And
that used existing statute.
And it used to be that you did have to apply, register with the DOE, ODE, and you don't anymore. And I can't fix it.
Okay, just trying to draw clear, bright lines here. On page 2, definition of finished product. I don't see why we need to delete that from finished product as a form of usable. I mean, I can see deleting it. That has the benefit of not weighing the entire brownie as usable marijuana. But I'm also concerned about other possible effects of that by finished products not being covered.
I took this out because of something Jeff discussed last meeting, and now I can't remember what the issue was.
What I had suggested was changing the words from when we said finished product is a form of usable marijuana. I had suggested changing that to finished product containing usable marijuana. That was the language I suggested.
But it says means a product infused with marijuana,
right,
so that seems redundant.
So, well, I think
with usable marijuana, yeah.
I think what you do here gets to the point that we're trying to get to, which is when considering the amount of usable marijuana in a finished product, it's only that amount of usable marijuana, and not the flour and the sugar and everything else that's in it. And I think you got at it here.
Okay. Could we just insert usable before marijuana? I just don't want to see. I like the intent of this. I just don't want it to see it unintended consequences. But okay. And then we get to the pesticide issue, of course, which since the last draft got turned completely on its head. The list of pesticides may be pesticides that we do not want to consume, and they may be common things that are applied to pesticides, or applied to cannabis. But it's a very, very short list of what people can potentially apply to cannabis. I mean, just look on YouTube and look up grow techniques, and you'll see a million wacky things that people put on. And of course, we can't test for all those things. But I agree with what Sheriff Crabtree said, that you know, perhaps simplifying this would be better. And all of these, this entire list falls under the category of 5 or 6 families of pesticides: organophosphates, organochlorides, carbamates, pyrethroids. And the way labs test for pesticides, they don't test for every individual pesticide on their list. They have reference standards for each of the classes of pesticides. So perhaps I would suggest keeping the OMRI definition and excluding that from the definition of pesticides, but I would also get rid of this list and just say that the facilities must see that the testing is tested for a minimum of these 5 or 6 groups of pesticides.
Could you get me that list?
Sure, sure.
No promises, but.
So the OMRI list, the reason that I took that out is when I did a little bit of research, it appeared that that was a constantly changing list. And we can't refer to a list like that in rules that's constantly changing without updating the rules every single time the list changes. That's the problem.
Well, it's a living document, so the
Right,
benefit
which
of
is the problem,
referring to
but
it.
we can't.
Right.
The statute can't refer to a living document either, so. But it's not legal to do that.
Right.
Can you freeze the OMRI list in time as what was
Can't.
legal on March
You can't.
1st, and then if it needs to be updated in the future, then it can be updated in the future?
I don't know how you go back in time and find what was on the list.
That's the problem.
I mean, I guess we could create an appendix A to the rules that contains the list
On a certain date.
on a certain date. That would be possible.
I mean, again, this is, as you know, because we're still having this conversation this late, has been the single biggest sticking point. And I'm open to any suggestions. I've heard loud and clear from the community, don't test for all 12,000 pesticides out there because you'll bankrupt the system. And I've heard from the patient safety, you got to give us some, you got to protect us from commonly used pesticides. So I've tried to find commonly used pesticides and say, if you're testing positive for these, it's a problem. I know exactly what's going to happen the minute this becomes final. Every distributor of pesticides and every grower are going to go and find something else. And I get that, I understand that, and that's why we need to be able to reach where to go to growers in the law.
Yeah, so I would encourage finding a way to use the OMRI if we have to make it static at a certain date. I mean, I think that for patient safety and it would be people's interest to encourage people to use these organic substances. That would help.
I'd love to see a law that says exactly that.
Yeah, because I mean the OMRI is a group of experts, and the list actually really does come from the USDA. So there seems like there should be some pathway of, I don't know, but we'll look into it more. But I think, just at least requiring testing for those groups, and those groups of pesticides, those chemical families aren't going to change very much.
Do you think those groups are going to encompass what would commonly be used?
It'll encompass all of this plus 1,000 more.
So if somebody would try to get around it, they would likely wind up using something in one of those groups.
No, if they use something in those groups, then it'll test positive for it.
Right, but I got the answer. I think.
So if we go with classes instead of specific components here, specific pesticides, are we actually going to expand what has to be tested for, and is that going to dramatically drive the cost up of testing?
No, because if a lab was going to test for each one of these things, each one of these things falls into one of 5 or 6 groups of chemical families. So the labs have reference standards for each of these groups.
So today, are those the classes that labs are testing for?
Yeah. Yeah.
Sounds like that's where you go, Tom.
Yeah.
So you're gonna give me a list.
Yes, I will. Yes, I will. Of course, I've got more things, you know me. Of course, we still need to address, maybe come up with another proposal for what happens when we receive applications that are within 1,000 feet of each other, but
Flip a coin.
I'm out of suggestions.
My bank number is?
Are you going by timestamp or just send button or receipt?
It's gonna be a huge problem, but
I got it.
I wish we.
I didn't create the law.
Yep. The signs, page 11, security and registered facilities. The signs, okay, just picture a 12-inch square sign about this big, with half-inch lettering, with 5 words on it. You're gonna, I mean, it just kind of creates an eyesore and doesn't really. Could we, make the signs smaller? I mean, I don't know, Noel, do you want a big blank sign with little tiny words?
It makes me think of fire code regulations that say this door to remain unlocked during business hours. Whatever guidelines and parameters they have, we should just piggyback on that. But yeah, I understand we were trying to get to a large visible sign, but I think devil in the details, it's like the 16-point font on the warning. We can accomplish the goal with a little better language that doesn't require weirdness.
This is borrowed from Colorado, if I'm remembering.
What page are we on?
I got it from someplace else, I didn't pick it up.
What page are we on?
11.
11.
Yeah. And also on
4B.
Thank you.
yeah, and also on 4A or 4 big A, that's under C, small C,
4C.
sub A. Yeah. I don't think the no minors allowed sign is appropriate under security because that's not a security issue. And I mean, and I think minors should be allowed if accompanied by parents. To see what medicine may work best for them. Not to try it out, but anyway. Back to testing on page 15. The language, the U.S. Pharmacopoeia, section 111. If we go with that, the whole program is going to shut down because their standards are colony forming units of 20 colony forming units for fungal contaminants, and there's no herbal product that exists that can meet those microbial standards. Everything has some mold on it, but I think we've discussed it already, and I understand the reasoning. But I spoke with the lead editor for the U.S. Or the AHP Pharmacopoeia cannabis monograph, which I do believe we've agreed to adopt when it's published. It's being formatted for the printer today, and it's going to the printer today or tomorrow, and should be officially published within 5 days. Of course, they've kicked this can down the road since June, but this is the most definitive I've had. So I'll let you know the moment I hear that the AHP monograph is published. The validated methodology for HPLC has been modified very slightly, and the microbial tolerance limits have been modified a little bit too, and he's sending me the table over sometime today. But I'll review those before we decide to go ahead and adopt them. But the AHP monograph will clearly be an appropriate reference for that, and so just crossing my fingers that it gets done in the next 5 days. And also for anyone who's interested in learning more about the monograph, they're going to be the lead editor or Dr. Michelle Sexton, who's another lead editor, one of those two are going to be presenting at the Advisory Committee on Medical Marijuana meeting in March. So keep in tune with that. It should be a very good presentation to learn more about that for future regulation.
So now, Todd, you're familiar with the existing medical marijuana testing facilities in and around the state right now, and you're also presumably familiar with 6B sub A and B, the 05 standard or the 09 standards, right?
Yeah.
Page 15. Without having gone and read those entire tomes myself, do you feel that the existing laboratories would meet those standards?
I've reviewed the T&I standards, and they seem pretty reasonable to me. And the iOS standards are pretty common among labs. I do have a note for me to just go back and bounce these off of some other chemists and lab operators just to make sure. But I don't know if they have to meet both standards.
That says or.
Yeah.
But just like the 1111 mold standard, we probably all have more mold than that on our shirt right now. We're not talking about intravenous applications here that have to be immaculately pure. In trying to be nifty and all-encompassing, are we throwing the baby out with the bathwater by setting standards that are unachievable and would immediately cut off all patient access? There is no lab that does this. Everybody's out of compliance.
That would be that would be inconsistent with the intent of the statute.
Precisely. So I think we all intend one thing to happen, but let's not inadvertently put something into stone that's going to tie our hands. So I don't know if these, I didn't go read it. It's kind of like reading an auto repair manual that refers you to section 7, and that's remove engine. Oh, that was a little more than I kind of bargained for today.
Well, the T&I standards seemed to pass my muster last time around, and since it's an or with the iOS standards, then I'm happy with that unless I hear otherwise. So.
We're trusting you, Todd.
Yeah. Okay. Page 19, down towards the bottom, sub A. I like that that the language was improved a little bit so that we don't have to keep immature plants in a cool, dry location. But I just wanted to put a friendly amendment there. Location with appropriate environmental controls, so as to prevent the marijuana plants from being contaminated or losing efficacy. Because I think if the medicine is in a limbo before the test results come, that MMF should have the diligence of making sure it's stored properly, just in case it has to be returned. They don't return it to their they don't return it in a lower quality than it originally was.
I'm not understanding what language you want to change. Right now it says usable marijuana imagery plants are segregated, withheld from use, and kept in a secure location so as to prevent the marijuana or plants from becoming contaminated or losing efficacy, or from being tampered with or transferred. So that's how they're supposed to be kept prior to testing. And so what do you want to change?
Right. Oh, so it would say withheld from use and kept in a secure location, and then begin my insertion with appropriate environmental controls so as continue to prevent the marijuana or plants from becoming contaminated or losing efficacy. Just
I think good product stewardship, anybody that runs a respectable shop is going to keep the plants under a light and a humidipack in a jar if it's going to sit there for a few weeks.
Yeah. Page 22, at the very bottom, section 8, says if the registration of the facility is revoked, the PRF must make arrangements to return the usable marijuana and immature plants in amount still possessed by the facility to the person who transferred the usable marijuana or immature plants, and must document the same. So I like that we're putting more thought into what happens with the marijuana. You know, we need to do something responsible with the marijuana if a facility closes, especially if they're closed because of violations or such. But that means that they would be giving their marijuana back to someone they already paid for it. And we can't really require the person who gets it back to pay the dispensary back for it.
There is no facility transfer.
And, you know, a closed facility would probably also have a great deal of expenses just dealing with closing. And
You can't transfer to a facility. The law doesn't allow it. The only place it can go is back to the person who delivered it. And they're gonna have to negotiate with the person they return it to for work out compensation. Now,
well, it could go to any cardholder, though.
Could it go to a cardholder?
Well, they're allowed to transfer the marijuana to any cardholder.
But if they've had their registration revoked, then they're not.
They can't transfer to a cardholder.
Right. But the moment they're revoked, they're still possessing their marijuana. So they're even in further violation of the law the moment they're revoked.
Well, I would imagine that the order, I would probably advise the authority that the order would allow a certain amount of time to divest themselves of the marijuana, but you wouldn't allow them to keep sort of operating like a normal facility would.
Yeah, I mean, it's a step in the right direction. I'm just having a hard time with
Advocating
it.
for a time window in there or something, instead of just leaving it up to policy and procedure?
Well, a time window would certainly help.
It seems to.
I mean, it would keep them from being in further violation of the law.
Right. If you're gonna close them down, give them a honorable exit sort of thing.
Yeah, in some way to kind of recoup their investment in their inventory.
If they reach the point where we're closing them down, I don't feel a need to protect them. I mean, frankly, you violated the law. You've done something that is very bad, and we're closing you down. And, you know, the product is no longer usable. It's no longer going to be going to patients. It's got to go back to the person who delivered it. Or, I suppose we could turn the jack and ask them to destroy it. But it's not going out to patients.
Except the patients that gave it to them or transferred
Except
it.
the person who transferred it into.
Yeah. Well, I don't have any suggestions
I don't
on that.
Change the law. I mean, you know, you've raised this a couple times, and you keep arguing why can't we turn around and sell it or deliver it to another facility. You know, the law changes, then we can do that. But right now, I can't do that.
But we can if the PRF is a cardholder. We can transfer it to another cardholder who may be the PRF for another facility. Can we have it be able to transfer it to a PRF who is a cardholder?
If you're operating outside of 3460, then you're back to on an A. These rules can't address that.
Rough one.
Yeah, it is. Don't get in trouble.
All right. And I'm trying to find something in here that Rob will just say, damn, that's a beautiful idea.
Okay. You have my attention.
Okay, anybody else around the table have any last minute thoughts or comments? We absolutely are ending at 12 noon, just so that everybody in the audience knows. I mean, we've gone through a lot of this. I will now open up to public comments unless somebody at the table wants to raise, and you may continue to do so as you hear things. Jim Clark, Jim, where are you? Sorry.
Could I ask a procedural question? Would you limit public comment to make sure that everybody who's signed up is able to testify?
Only 4 people.
Oh, okay, thanks.
That means they get double time.
See,
I'll keep
you
it relatively short.
You highlighted that they can ramble on.
For the record, my name is Jim Carr. First off, I'd like to thank everybody here for doing what I consider to be a great job. I've been on the ACMM since its inception. Know most of you here. quite well. And I only have a couple observations that may already work into what you kind of concluded in this draft 4. One was under the ability for employees to have a break room where they can use their medicine while they're at a facility. As wanting to promote and planning to open a facility myself, I would like to say that for the progressiveness and what we need in facilities in this project in the state of Oregon for the patients in particular is the ability to do some kind of research. And so, you know, if we're going to allow our employees a place to smoke within the facility, I'd like to be able to use that same area as a place to do specific data collection from patients based on the scientific collection of data per prescribed date or time. And the reason for that is prior to the Oregon program, I had an organization I worked for in Humboldt County, California, called the Humboldt Research Institute, and we did a lot of patient research stuff where we had 181 patients that came in. They were given 2 different types of medicine, maybe an eighth of each. They were marked A and B with about an 8-question questionnaire on it. They took it home according to their specific issue, and then they filled it out and brought it back. And like if we want to make a little more advancement and say glaucoma pressure, whatever your specific ailment is, we'd like to call upon those people to bring them in and collect that data at our facility. And that would, you know, mean the need to, you know, allow them, but it could be after hours.
Yeah, Jim, I love the idea of research. I mean, I think that's what the community needs to be heading for. I just don't know whether we can reach it under 3460. I just don't know whether we can allow you to do research.
Right. I was just wondering if within the policy of the facility itself, if that would be deemed.
Well, I mean, you can have a conversation and, you know, what your patients can choose to disclose, whatever they choose to disclose to you. But I don't know that we can specifically authorize the use of research, because I don't see that word anywhere in 3460.
No, this would just be a facility policy to allow patients to actually consume.
You want to consume on premise for the purpose of research.
Yes.
I got it. Okay.
In the same area that you're already.
Okay, I got it. That it's not. It is a consume on premise issue. It's not a research issue. I mean,
right.
Yeah, I got it. Okay, I understand what you're
To
talking
fit into that now that you've already, I seem to go positive for the employees.
Yeah,
it would
yeah,
be
fine.
done in the same room, just a different.
I got it. I understand what you asked.
I was also curious about whether reference standards, as they are now, are done with researched data on human toxicity. In other words, if we have to do a testing for pesticides at a certain level, do we know, is there data, and can that be supplied to us at the facilities as to whether or not, you know, is .001, you know, the absolute bottom, but at .003, it may also be inert to the patient. People who grow in dirt, for instance, the ground itself has pesticides and stuff in it. So when it comes in, after a while, they're kind of flushed out of whatever's being grown there, and it's okay. So do we really know that it has to be .001 or can it be .003, which could mean to the testing facility the difference of a $20,000 machine.
Yeah, no, we're relying on other people, the Department of Agriculture, our laboratory people to come up with those standards, and I unfortunately can't answer that. So all I will do is ask the question for you.
Okay, will there be a like a booklet for the MMF of maybe what is acceptable, particularly those who
Not from
choose to
us.
have the in-house testing?
Not from us. I'm sorry, I just don't see us doing that.
Okay, and I'm not sure if I heard the answer to this question about the forms going to be used between the patient grower and to the MMF. Have those forms been released?
Yes,
Or is
they're
it-
on the webpage. And
is
the
it-
drafts are on the webpage. I want to make it clear that they're subject to change, and the final forms will be posted sometime at the same time the rules are posted. So they're there, they're available to you to look at. If you have concerns about the way they read, like Noel raised a question about something, let us know.
Okay, thank you all very much.
Okay, thank you. Lee, did you want to make comments? You're number 2 on my list.
Thank you, Tom.
All right, you've got the same 5 minutes he took.
Thank you very much. I'm really excited about the news that Todd mentioned that cannabis is going to be included in the pharmacopoeia for herbal medicines, because it's important to know, Tom, it's not product. It's a non-toxic herbal remedy. It's not kryptonite. It's not evil. It's not a product. It's medicine in this context. Regarding Jack's concerns, I don't understand why the labeling doesn't include a recommended dosage for the edibles, for the medicated edibles. I know you can't regulate the person who is manufacturing the edibles, but you can require that the facility not distribute medicated edibles that don't include a recommended dosage. As a non-patient consumer, I had somebody come by and bring me some gummy bears, and I forgot to ask what the dosage is, so now I need to call them because I don't want to over-medicate it. It leaves me disoriented. It's another important thing to remember about marijuana, that unlike, and why it's not a pharmacy, Rob, is that there's no functional lethal dosage like there is with dangerous medications. There's no, what there is, if there's an overdose of cannabis, is people go to sleep. Or they get disoriented.
Pharmacies dispense lots of drugs.
No, I know.
Controlled substances that have no lethal dosage.
I understand, but the prescribed medications all have lethal dosages.
No, they don't.
They have LD numbers. You know.
Some of them do, some of them don't.
I'm just saying that's the difference, and that's why, because the dispensaries, the good dispensaries that exist in California and British Columbia are holistic health centers. They include, just to finish this point, they include acupuncturists, they include Chinese herbal medicine people, they include massage therapists, and they include places where patients who are often lonely and isolated can get together and use. So it's not that it's this big party going on, it's that it's actually there's therapeutic value in it. In that regard, what I was going to ask was, is it possible, I've been struggling since I work with some facilities that have lounges inside, what does it mean to have a different location? And I heard here today that a different location means a different address. Could we include that in the definition section, please? I think it would lead to less litigation and the less possibility of prosecution, that distinct address. Whether that means you could, if you had a building, you could have, you know, Unit A is the dispensary and Unit B is the facility, is the lounge, is less clear to me, but it's at least better than just leaving it a separate location and leaving that undefined.
So Lee, while you're thinking, I'm going to go back to your first statement about putting on the package for medibles what a dose is, because I love that idea. But my question to you is, what are the standards by which that is determined?
The standards by which that would be determined is by the person who's manufacturing it.
Okay, so you would leave it to the manufacturer to say, the one gummy bear per every 4 hours.
No. It's not like that. Because, excuse me. One thing that differentiates cannabis from other dangerous drugs is that it's a PRN drug. For many patients, it's a take-as-needed drug. The reason why people smoke marijuana who are patients is not to get high, Jack. It's because they can titrate their dosage. It's because if they are eating something,
So
then
come back to my
or
question.
if they're eating something, it elevates them quickly to a level kind of like dangerous drugs like oxycodone, where they're not able to function. I think the answer is that the dispensary shouldn't be allowed to sell something that a manufacturer has not included a suggested dosage for. And by suggested dosage, I don't mean take every 4 hours. I mean, if you take more than, it's not recommended that you use more than half, because if you use more than half, then you'll experience this side effect, which is extreme disorientation, the impairment that Jack and others in law enforcement are concerned about. I mean, speaking as a non-patient consumer of edibles, those are the concerns.
And the point that Lee is making here is the reason why earlier I proposed that we report herbal cannabis lab results in percentage and edibles in milligrams. Because if you have your sample size that says it has 14 milligrams of THC in it, then 14 milligrams is kind of an average dose. And then it comes down to kind of patient education of what 14 milligrams means to them.
And I think that's the industry standard, isn't it? That edibles are if you were to go into a dispensary in California or in Colorado, that the edibles would be listed as has this many grams of usable marijuana in it.
It's an emergent part of the market.
Well, it's an emerging part of the industry. I mean, I think the important thing that's been kind of overlooked, and respectfully, Rob, I agree with Anthony, the cannabis industry is really, in significant ways, different from the alcohol or tobacco industries. And partly, and one way that it's different is my anticipation is that through the Oregon Cannabis Industry Association, the National Cannabis Industry Association, and others, the industry itself will create standards that are higher than the rules that this committee recommends and that OHA promulgates. I think that's a reasonable expectation. That's the kind of people who are involved in this. It's kind of like the normal legal committee. We're not all consumers, but many are. The same thing is true with the people who are involved with the distribution of medicinal cannabis. They recognize that it is a plant that can save the world. They recognize that they are doing good by doing good. They're compassionate people who want to make their communities better and more safe, not less safe.
And I love your optimism, Lee. It's just my experience in this building with the other industries you mentioned, is that when they have that power, money, and influence, things somehow change. When they become a large, legitimate industry with a lot of money and a lot of power and a lot of lobbyists, a lot of the goals that you represent here today, I wish everybody was operating like you are. I am just a pessimist when it comes to large industries and power in this building.
I'm just advising people about how to comply with the Medical Marijuana Act. I'm not a member of the industry beyond that.
I understand that.
Just to
I
clarify,
love your optimism, but I don't share it.
I understand. And in that regard, I guess I encourage you at the end of January, there's going to be a conference in Ashland, Oregon Medical Marijuana Business Conference. And I think the theme that you'll hear throughout the conference is going to be the theme that I'm describing. That because the purpose of distributing cannabis, whether it's medical cannabis or cannabis for responsible adult use, is to end prohibition. That's the point. And if we're not going to get from here to there, if we're unscrupulous, like the alcohol and tobacco folks are, we've been asking for the legislature. I mean, I've testified in this building, and we've been asking in the legislature, and the advisory committee's been asking in the legislature since 2005 to give the authority to the authority to do science. And we haven't been successful in being able to do that. And unfortunately, the authority, and when it was the Department of Human Services, took the position, as they take, frankly, with these rules, that they can, and as Jeff sort of highlighted, I think, in one of his comments, that they interpret their authority broadly when they want to, and they say they don't have the authority and when they don't want to act. And so I'd like to see, Rob, I wanted to know too, are you going to post the letter that you're sending off with all your suggested changes to the webpage?
Oh, you mean to 3460?
Yes, sir.
I guess I could. I wasn't planning on drafting anything right yet, but I'm happy to share it.
I did have.
Is that something you'd want to even post? Because it doesn't affect the rules, it affects 3460.
Okay, well, I've offered privately, and I'll say publicly, I'm certainly willing to do something jointly with you on that, and I have two suggestions. One is the notion that a patient can authorize the grower to distribute the excess medicine that the patient doesn't need, to a facility, and then has to go to the patient and get the patient to sign a form about which facility is ridiculous. And the solution, I think, is to allow the patient to transfer ownership in the excess to the grower and have, and I think, and be remunerated for that from the grower, and that not be a transfer for consideration, which causes you to lose the protection of the Medical Marijuana Act. I think that's the easy solution. And I think the other thing is, adding in the science and research thing.
Can that be done by rule?
The science and research?
No, the transfer thing you just mentioned.
I think not. I think Amy pointed out to me that there's that section, and in working with Jeff and Sam in the legislature, I didn't see it coming, but it says pretty clearly.
It's been in there since the very beginning of it.
Right, that the patient directs, and so I think that, I can draft for a grower a document that transfers the ownership interest for no consideration, but that's not fair to the patient. If the grower is able to set their own price, and they are under this scheme, I think, then the patient ought to be able to get cut in on that. If it's a valuable thing, then they should have a part of that.
Lee, I'm going to give you one more minute.
Yeah, I was trying to remember the other thing.
You seem to be very interested in the definition of finished product.
I was interested in the definition of finished product. I think that was resolved well today. The requiring usable in front of marijuana. And I think that'll help also with litigation. Todd and I had a case in Hillsborough, along with Greg Melby, Todd testified, and Greg Melby, who's a physician in the Dallas, testified about hashish being usable marijuana. Judge ruled that it wasn't. I filed a brief on appeal, and the Attorney General conceded it. It's before the Court of Appeals about whether they're going to accept the concession right now. I don't need to do that. I'd rather not do that litigation.
Okay.
I do remember the last thing. The last thing is that the advisory committee has repeatedly, whether it's been in regard to rules for the dispensaries or rules for the authority generally or adding new conditions, urged the authority to appoint people who have backgrounds and basic knowledge of cannabis therapeutics. Knowledge, for example, that there is no reported study about harms related to secondhand cannabis smoke, just for example. And I think that that's perhaps either needs to be worked into 3460 because apparently the authority is more interested in hearing from opponents of the law than they are from hearing from people who, like Todd and Anthony, that have the training in this area. So
I thought we had a pretty balanced committee. Yeah.
I know that you did, and respectfully, it's a thing we disagree on.
Okay.
So, but I would encourage you to include that location thing. That'll really help out, I think, particularly as to existing facilities that have lounges. And the last thing is, I know that you're all, or mostly all, volunteering your time here, and I really appreciate that, and I wanted to thank you all for your service in this regard.
Thanks, Lee. We'll be back. Jordan Culver.
Hey guys, thank you first off for all your work on all this. I'm Jordan Kober. I run Oregon Grow magazine. We do a lot of articles on everything that's going on here, as well as patient advocacy articles on growing, testing, things like that. And I've been in about 100 dispensaries this year on business, and also just stopping in to get a feel for what people think about 3460, about the rules, about cannabis in general. And I think more than anything, what I'm hearing right now is a lot of concerns about on-site consumption. And I love that you guys have been kicking it around so much. I really appreciate you, Anthony, bringing it up today. You as well, Amy, everyone that's commented on it. You guys have done a great job at keeping that issue around. I think it's important not only to business operators, but also to the patients. And I wanted to touch on something that Lee just barely touched on, but I want to get to this notion of what I'm terming social shut-ins. And these are essentially the patients that are, over 50, have severe pain or psychological issues or whatever the case may be that they're using cannabis for. But these people, for whatever reason, don't leave the home. They feel isolated. They feel like they have a condition that's stigmatized. They use a medicine that's stigmatized. And they don't have a lot of interaction with people that are like-minded, that support them in using this medicine, and that they feel they can have a conversation with, not even necessarily about cannabis, but just as a human-to-human interaction, without feeling that they're being stigmatized or judged. And I was recently at a place called Alternative Remedies in Portland that I think is doing a fabulous job of helping patients out, educating them, providing a really awesome opportunity for safe access in every way that they can. And I talked with a man who actually started crying, and he said, Tuesday is the worst day of the week for me, because Tuesday is the day that this place is closed. And he wasn't saying this is the one day I can't get high. He could do that anywhere. That was the one day of the week that he can't get out and talk to people, and he's just stuck at home reading his books, playing on his computer. He doesn't have social interaction. But when he's there, he can talk to people from all over. They're doctors, they're lawyers, they're patients like him, they're caregivers like him who have a similar interest, but who are also just people, and who will talk about politics and talk about whatever comes up, and he feels like he is comfortable there. He can smoke a joint, he can hit a vaporizer, he can eat an edible, whatever the case may be, but he knows he's among friends there. And for him, that social aspect of cannabis is as valuable and therapeutic to him and his healing as the plant itself in any form. And I think to take that away is really something that's being missed in the issue of on-site consumption here. It's not necessarily that people just want a place to go and smoke a blunt and listen to a rap album. They want a place that they can feel like people again. And I think that's really valuable. And beyond that, I think in terms of on-site consumption, I love that Amy brought up that there's a possibility to do on-site consumption that isn't necessarily combusting plant matter, that you can have an e-cigarette that doesn't smell like anything, or you could use a volcano vaporizer that just produces a bag of semi-transparent vapor. It's essentially water vapor with cannabinoids in it. It doesn't smell. I personally get cannabis massages twice a month at a place that does cannabis massages. I know a person who's a licensed massage therapist. She makes a cannabis salve. It smells like peppermint. It doesn't smell like cannabis at all. It's completely organic. She gives me an hour-long massage in this dispensary that has a separate massage room, and I feel great for a couple days. I'm pain free. Now that on-site consumption to me doesn't violate a Clean Air Act. It doesn't constitute getting high. It doesn't put the public at any risk whatsoever. Someone's putting jojoba butter on my back on a table while I listen to Enya. It's not terrifying. Beyond that, the patients that are in here, these employees that work in these places, they're patients like me. They're not concerned about the quote-unquote quality of the air if it has smoke in it. They're smoking it with the people that are coming in. Their concern isn't, do we have the right carbon filter to filter out the EPA standards of molecules in the air here? Their concern is whether you're puffing twice and passing, and if it's passing on the left-hand side. That's their concern. So people need to realize that we don't have to, as Amy said, reinvent the wheel here. We don't have to get into every minute detail about air quality and EPA filters and what pesticides are okay. I understand the concerns. It's motivated from an awesome place. It's motivated for a genuine concern for the public. But I think that when you're in these places and you interact with them as frequently as I do, 5 to 7 days a week, all across the state, you see that this is essentially a non-issue for everyone involved. Beyond that, you can use carbon filters. It doesn't have to be $1,000 of air filter. I'm a grower. We grow 24 plants in full flower, 6 feet tall. We have a carbon filter. You walk into the room, you cannot smell those plants blowing up against each other, rubbing resin into the air everywhere. You can't smell it inside the room 2 feet from the plants. You can't smell it outside the room. It doesn't get any stinkier than 24 plants in full bloom. I mean, that's going to smell way worse than someone burning a joint, and you cannot smell it. I've been in many places where you walk in and there's no smoke in the air, even though there's on-site consumption, they're filtering it. I've been to cigar bars where you walk in and it's a white haze you can't walk through.
Point, please.
Thank you. So beyond that, I would like to ask who will enforce this blackout period that happens between March 1st and whenever. Tom, you said that it may take a week to process these, so you're thinking about 52 a year. That's 104 in 2 years. You're going to receive at least 200. You're going to receive 400. And that means that you're talking about these places are going to shut down. They're going to do build out, they're going to pay rent, they're going to do all these things with no income and no certainty about their future in a complete blackout area where they have no ability to determine who's even applying for licenses around them. It's ludicrous. You would never ask any other industry to even face a challenge like that. So
The legislature gave them 4 FTE.
4 FTE?
4 employees. That's all the legislature gave them.
So there's not going to be any enforcement then is essentially what it comes down to.
That is correct.
Okay, thank you guys.
May I ask you a question?
Yes.
Well, first I just wanted to comment on something you said earlier.
Yeah.
So some things you said, I mean, it resonates. I mean, if you ask any patient who's gone, to have their chemotherapy drip or their kidney dialysis, in these clinics or hospitals where there are rooms. I've heard a lot of stories from patients who had experience taking their medicine in those environments that just the community sense of going in there and doing my dialysis with my buddy is incredibly valuable. So I just wanted to comment on that.
Thank you.
And also, I rarely meet someone who's been inside more dispensaries than me. So I must ask you, and you alluded to this in one of your comments. Can you give us a good idea of how many facilities you anticipate will be hitting the enter button on March 3rd?
I would say at least 100 from Portland alone. I would think surrounding, like statewide, at least 200, and I don't think 400 is out of the question for applications.
Okay.
I don't think all those places will be able to comply. Pretty much across the board, everyone I know is already trying to get compliant. They already have separate points of entry. They already have security systems. They already have safes. A lot of places have even stopped on-site consumption just because they thought, well, we're not going to be able to do this. So I think the spirit, like Lee said, people do want to get ahead of the ball on this. They do want to be as compliant as they can before there's even a requirement to comply. I know people were labeling, doing things like that on edibles. That's not the case with everyone, but I think that those people will, for lack of a better way to say it, will separate the wheat from the chaff in that. There's people that will be ready to comply and be business-minded, and there's people that don't have the right interests or the ability to be business-minded or business-compliant, and they'll fall through. So.
And I appreciate your concerns about what's going to happen on March 3rd.
Yeah.
And all I can tell you is that we anticipate a rush, and we will move as quickly as we can to get it out there. And I think Rob's comment is very well taken about what will happen in the interim.
Yeah, I'm concerned. In Multnomah, I think they kind of know that no one's coming for them right now. The March 1st and March 2nd aren't any different in terms of dates and what actually happens to them. But I think that other places might be concerned. Maybe local enforcement knows, like, March 2nd, I'm going right there.
I'm stuck with what was handed to me.
Thank you guys so much. Appreciate you.
Thanks. Rodney Webb.
As everybody else mentioned, I really want to thank everybody for their time. I think this is very important. One of the things that I like about stuff like this, I've been to a few CANA conferences, and this is an industry, and it needs to be treated like a profession. So the more we do that, the better off we are, and that's what these meetings do, so I appreciate that. One of the things I would suggest about the rooms, the carbon filtration, I know it's been hit on, this social interaction with using medicine. One of the things that can be done is create rooms that don't ingest via carcinogenic smoke. So the typical joint smoking could be eliminated, and you would satisfy a lot of people with being able to ingest. So that's a thought. Carbon filtration, as was mentioned, does not have to be extremely expensive. It can be something that can be looked into to solve that problem. Also touching on the suggested dosage issue, requirement to level of medicine in an edible makes a lot of sense on a lot of levels, and people already do it. And what that does is it becomes a point of patient responsibility here. A suggested dosage for myself is going to be different than for Noel, than for Anthony, than for anybody behind here, because of how I chemically react with cannabis. That's a fact that we have to acknowledge for this. There's no perfection of X amount per Y amount of time. But by having the level of medicine in there, what a person gets to do is go, how do I react to this level of medicine? Or do I pill split it, split my gummy, split my dosage, and go from there? But speaking to your point, Mr. Cowtree, the labeling of candy-like things with serious labeling is important. I have a 9-year-old daughter. I don't want her to take a lollipop by accident. So that all makes a lot of sense. We are working with people who warn on there, this is medicine, and then they have dosage amount. And then it becomes patient education. Patients need to be responsible for themselves. That's one thing I think that does get a little bit lost in this. We're trying to help people. They also have to help themselves. I'm a patient. I have to know how this medicine works for me and with me. I can't lay that on you. That's not fair. Or OHA to tell me how to take my medicine. So with those minimums of this is not for minors, this is medicine, and this is the amount of medicine in this thing, that goes a long way to helping people get to where they need to be and not overdo. As far as child-proof containers, that's been a concern. That was also, I believe you brought up, Mr. Crabtree. That is being addressed in Colorado as we speak. I spoke with a manufacturer at the most recent conference just south of Seattle a few months ago. Here's how it works. You get an opaque container, that's the law there, can't be see-through. That container looks similar to a prescription medicine bottle. It fits into a container that locks, that looks like a bigger prescription medicine bottle. It has a key lock on the bottom. It's not a child-proof, can push it down, because they're protecting under 21, according to them. So that's someone who could easily open a child-proof container. Those containers already exist. They're on the market. I don't see them not being potentially, they could be potentially useful in the way you guys make the rules versus the statute. So it's something that potentially we can look into, and maybe it's in the future. In addition, there could be guidance. I would call it like a public service announcement that goes through the OHA that says, here's the kind of container you can have at home that locks, that keeps your medicine at the right humidity and temperature. They exist already for other things, but it could be again, a guidance to inform patients of how to store their medicine, keep it childproof, and then the potential level of raising that containers are already existing for transportation and for transacting. So they are out there, so these solutions are thought about. And then lastly, in terms of the labor law, I thought Amy hit on it. The challenge between 1099 employees and volunteers for this group is basically impossible. If you've had any study or dealt in that field, labor law, how ancient and strong is that? I think we rely on what, as was already mentioned, going to the nonprofits who work with labor law. How do we integrate how you're working in the real world in this industry versus us being its own little zone of specialty of 1099 employee volunteers? Just my thoughts. Again, really appreciate that you guys are working on this. This is important. Even when we have not the same look at something, it feels like people are working together. And you can't say that a lot about a lot of places and people, so thank you.
Rodney, I appreciate it, and your thought about getting into the issue of containers is something that I'll put on my list for future conversations. Lauren? And in case anybody's interested, you're it, buddy.
All right.
You're the last person, last word on this.
This came up this way a lot. I think I should be used to it.
Tom, can you hear me?
Yes.
This is Kelly Matting with Jackson County.
Okay, Kelly.
I didn't
Not yet,
know
Kelly.
about this meeting until 7:30 this morning, so are you allowing information to be provided over the phone?
Kelly, hang on a second, I'll get back to you.
Okay, thank you.
Okay, Lauren, go ahead.
Good morning. Wow. So, Jordan, thank you for your talk there, but I got to say something. My experiences, okay? My experiences is that I'm being told by my patients that they enjoy the fact that they can come into my establishment and it is very professional. It's got discretionary entries. There's only one person allowed in the containment room at a time. They like the fact that there is no smoke in the air. They're not walking into a place where a bunch of kids are laying on lounges or whatever and smoking. And I know I'm not going to be very popular with this, but that's kind of the hard job at times, is that my patients come through my clinic. I've been running a clinic in Salem for over a year now, and their average age is 52 years old. And they come from all professional walks of life, and they're there because they're very sick, contrary to what Lynn County politics is saying. Most of them have very debilitating conditions, and they need this medicine. And I just can't ever believe that, and again, I'm sorry, that people would feel it's okay to walk into a pharmacy and open up a Vicodin and do it there. So that part of it kind of confuses me from what I'm trying to build and what I see as being professionalism. My doctor has 2 PhDs. He has 2 master's degrees, including one in nutrition. And everything that we're investigating now is Jack talking about different types of medicine delivery. We're looking at CBD strictly and coming away from the THC. And we're looking at creating smoothies and doing these things that don't even have any psychoactive principles or effects for people. And these are the people that are coming in to where I'm at. Maybe I'm catering to the old fogey crowd, or I don't know what it is, but I know that it's different. On our point of sale and our MMJ menu, we track all the conditions when they come in. We look at what they're being prescribed, or excuse me, what's being recommended for them, and how it impacts them every time. So in that way, we can move. Most people, myself included, I don't like being high. I have to take the medicine for my arthritis and the debilitating conditions I face. I do so because it helps me. But quite frankly, I like the way I think. I like the way I interact with people. I'm fine with that. And it doesn't fit exactly what other people may feel or how they see about it, how they see themselves. I understand that the psychoactive part is very important for certain mental disorders and things that people are facing. It impacts how the depression, PTSD, generalized anxieties, all these are impacted by the THC side, I believe, and other cannabinoids that are CBDs that are present. But that's just how I look at it. Like I said, we're working hard right now to look at, how do we get more of the CBD and less of the THC, because that's the people that are coming in to where I'm at.
Appreciate it. And do you have any specific points on the rules?
Oh, I'm sorry. The same thing I've said before is that, again, I don't understand how I have to have an address to apply for registration. That I have to be registered with the Secretary of State to apply. But when I do that, I'm not protected as an entity. My address isn't protected even though you're asking for it. So I'm just beating a dead horse that way. Go ahead.
I guess I don't understand. You mean you're concerned about the fact your address will become public?
No, not at all. I'm concerned that you're asking for an address to be static, right? But then you're saying, okay, while you're static, if this guy comes in and moves in next door to you and has a faster internet connection on March 3rd or is more savvy than you, that he can apply in front of you and all your setup and hard work goes away.
Got it.
So, and I think there's a lot of ways to verify those. I mean, we talked about it one time before about the business licensing itself. So, but thank you for your time.
All right, good. Appreciate it, Mark. Kelly, you have 1 minute, and I apologize for that, but we've just got to be done.
That's okay. Kelly Matting, Jackson County Development Services. I did notice that your new section 1110 has the sort of disclaimer, if you will, the number 2. that registration is not, by the authority, is not a guarantee that the facility permitted to operate meets local land use laws or local laws. I didn't see that same language on the application and would hope that that language would be put on the application, given that the application is 2 pages already. Seems like you would have some space on there to put that on.
Yeah, Kelly, the application will become a document on a web page, and it will be on the web page. It's not
Okay, that sounds good.
It's not going to
So
be a
thank you
paper
for that.
application.
The other thing is, I noticed that in number 4 of that same section, you took out the requirement that a governmental entity needed to provide the PRF with the zoning. So you're not requiring them to come in to their local land use counter to get that, basically just that information?
Correct.
So can you tell me why you took that out?
I think it was taken out because we came to the conclusion that ultimately we're going to have to be looking it up as opposed to them looking it up, and so all we want them to do is come in and say 527 West Main, as far as we can tell from Jackson County, is in a zoned area, and then we're going to have to do the work. And getting you involved on the front end is something that we didn't think we needed to do.
Okay, so as long as the application has the disclaimer on it, I think that we can live with that, because really the goal was to have a dialogue, or be able to have even a brief dialogue with the facility person to talk with them about potential zoning issues, which now they're not going to do, because they're probably not going to come in. They're just going to give you an address.
So,
and I think that while I understand your perspective on that, I think that frankly is a disservice to your customers, because they won't come in and talk to us about that prior to them just submitting an address to you.
Shannon, do you want to weigh in on this?
So just to point out on page 9, they do have to provide us with some sort of document that shows what the zoning is for their location. It's not going to be anything that's signed off on by a local governmental entity, but they have to, show us something so that we know what the zoning is right there.
Yeah, Kelly, we understand your concerns and the fact that you want the dialogue, and we're hoping that they do the dialogue, but it's not our issue.
Right, and I understand that. I just wanted, it becomes our issue. And
Yes.
I was hoping that through this rule adoption, maybe our issue could be alleviated a little bit. But that's okay. I understand where you're coming from in your perspective, and I appreciate you including number 2 in that section.
Okay? That it?
Yep.
Okay, and I apologize you didn't know. It's been on the webpage for a week or so, so I don't know what happened with the webpage, but anyway.
So I think what happened was you guys send out an alert that the meeting is going to transpire, but that alert didn't come out till this morning. And that was just it. I was waiting for that alert, but it's not a problem. I'm glad I was able to. The roads are terrible anyway, so I wouldn't want it to have driven anyway. So I'm glad you could do this through the technology you have.
That's a serious failure in the alert process, because every time that web page gets changed, it's supposed to automatically alert, so I'll have to back up and find out why. PK, last words, please.
Thank you
30
for
seconds.
coming here and listening to and having a conversation about this. The patients need you, but the patient is different than a regular person. Because he uses cannabis as a medicine to relieve the pain, to relieve what's in his head.
We're doing the best we can, PK. And we appreciate your help, and particularly your broadcasting this for us to get the word out.
Thanks for Channel 23, Comcast.
Okay, thank you. Okay, for those of you who are interested,
This is William Edmondson from Malheur County, and I just have one question, if I may.
William, I'm sorry, we have got to end this. I don't have time. If you want to send it, please feel free to send me an email in the email address. I need to be out of here in 30 seconds. I apologize. It's not my control. For those of you who are interested, this will be ultimately posted as a temporary rule, probably in mid-January, and those will be the rules by which you will function under when you apply. I can't guarantee that everything in here that you see will be up to me what's done in the internal, but it'll be very, very close to this. The temporary rules will be in place as early as we can get them through our internal process and up posted to give you as much time as possible. Watch that website. The fact that it didn't work concerns me, but it's really your responsibility to watch it on a daily basis if necessary, because we will be posting things there, and you will see the forms, you'll see the rules, and you'll understand how the process will be to actually apply online on March 3rd.
When will the rules be finalized?
We will do a temporary rule and do a parallel permanent rule process. That permanent rule process requires a longer time period than I have because we're late in the process.
When do you expect that to be?
I expect it to be parallel, and I expect it to occur as soon after that as we possibly can. I
understand.
I don't understand that side of it, Lee, except to say that.
Well, there's notice and comment. I mean,
and that's and there is through the permanent process an ability for a formal comment period. Those formal comments, we will travel around the state. We will get 3 or 4 locations. They will be notified. People can, so they don't all have to travel.
But that can't start until the temporary rules are promulgated.
Right, that is correct.
And you don't have a sense about how long that takes? Then that's
the temporary rules.
So for temporary rules to become permanent rules, it takes about 2 months or so?
No, we must do it within 6. If we post these on January 15th,
yes,
the permanent rules have to be in place by July 15th. And there's a timeline that leads up to that. We're going to do a parallel process that meets the requirements.
Okay.
I'm not an expert. I don't know. That's I just don't know, Lee. I don't have an answer.
So the rules can still change after the temporary
We cannot
rules.
make policy changes. It's the kind of, there's a, we left the word out, we left the 2 out, we had a spelling error, we had those types of things. There's little tiny things that can change, but my rules coordinator says the temporary rules better be awful darn close to what your permanent rules are. You can't do a major policy change.
And the temporary rules are different from emergency rules?
Yes.
Yep.
No, there's
I
no
don't
such
think
thing
so.
as emergency rules.
Yeah.
Okay.
Yeah.
Can I say something?
Yeah.
So, despite the constant battering of House Bill 3460 for the last several months, I really do just want to thank everybody who spent their time and energy on this committee. I actually think this is a very workable set of rules, and just wanted to express my thanks to everybody who worked so hard on this.
And I want to thank everybody on the committee for putting
and that thanks extends to the agency and the Department of Justice and Shannon and Tom and all the folks that work so hard with them. They have been absolutely outstanding throughout this whole process, and I look forward to continuing to work with them. So thank you all.
Okay, thank you all. Appreciate it.
Do you want to say anything before I turn it off, Glenn?
Yes, good night.
Good night. God bless you all, every single one of you.